Sicela uNkulunkulu engcwele usiphe ukuhlakani okufanele ukuze uNkulunkulu engcwele impilo zabantu. uNkulunkulu engcwele sazi ukuthi iphethwe wena before uNkulunkulu engcwele ziphathwe yithi. Siyakhuleka nangalesikhathi ukuthi ube nalomhlangano. In Jesus' mighty name we pray. Amen.
Thank you very much, Sibapiwe. Colleagues, I'll be co-chairing this program with the colleague from HSRC, Dr. Lehlohonolo Makola. She will bear with me when I'm not pronouncing her surname right. But she's here. We are just sitting here in front with her, so we'll be co-chairing the program with her. My responsibility for now is to welcome everyone. I'm sure I'll also give Doc an opportunity also to welcome other stakeholders that are here. But for now, maybe as the province and as the province of KwaZulu-Natal, as the office of the Premier, we are here just to welcome colleagues who are amongst us or who decided to abandon their holiday, because today, as much as it's a work day, but some people would have taken a leave in order to have a long weekend. But you decided to be here, so we really appreciate that. So amongst the colleagues that are here, we have colleagues from government department led by the office of the Premier. When I'm saying government departments, all the government departments that we have in the province, or Department of Health in the main, social development, education, almost all of them, because the issues of HIV in the province of KwaZulu-Natal are not issues of Department of Health alone, but it's a societal issue where everyone is contributing in terms of fighting the scourge of HIV and AIDS in our province. So that is why all those departments are here. We have the civil society, Imbonile Ubabu Mtia, and Unopala, Uzikona, it's just that they are sitting in a different seats, but we can recognize you. As well as Usagara Nopala, oh, she's here, yeah, she's sitting over there, because I must recognize them. I can't just say the civil society led by the chair and the secretary, no, otherwise. We have different sectors, colleagues, people living with HIV, LGBTQI, research sector, institution of higher learning. I saw Prof there. She's also with us because we're also working with issues of higher learning in terms of HIV and AIDS, as well as other programs. We have districts that we are working with. We have our social partners. In the province of KwaZulu-Natal, we have 11 districts. We are having 10 districts and 1 metro, because we're only having 1 metro in the province of KwaZulu-Natal, but we also have those 10 districts. I'm not going to name them one by one, but they are here with us. We have our developmental partners, we have AFSA, we have PEFA, we have USAID, we have CTC, we have Prof. She's here, Prof. Luvuno, as well as Prof. Ngama and Ukalema. On the academia side, we have UNFPA, we have your Caprisa. So those are the stakeholders, colleagues that are here that decided to abandon their day for this program to happen. Colleagues, you are all welcome. Maybe I'll hand over to my colleague so she can also acknowledge other colleagues that maybe I omitted in terms of the provincial stakeholders, because the one that I was talking to are just provincial stakeholders. Over to you.
No, thank you so much, Mr. Mzimande, and happy Heritage Month to everyone that has joined us. We are grateful that you are here. I think you have acknowledged all the stakeholders that are supposed to be here, including the colleagues from HSRC that are in the different tables, and SANEC National that are also here to support this event. We are very happy and also glad that the Premier's office and the team that was led by you, Olile, have done an exceptional work to ensure that this day is become a success, or people are able to attend as well. So colleagues, just to start off by taking you through the program, it should be in the package that you received in the morning. We, as Mr. Zimande mentioned, that we are 30 minutes delayed, but we still hope that we'll be able to recover and finish off the day as activities by 2:30. But just to note that we are going to have an address from the Center for Disease Control and Prevention. We will have Dr. Amy Du Bois, who's the Deputy Director for Health System and Strategy from CDC South Africa, giving that address. That would be followed by the HSRC team led by Professor Kangalani Zuma, who will then present the HSRC's SABSSM Provincial and District level results of the South African National HIV Prevalence Incidence and Behavior Survey. We will also be joined by colleagues from CDC that are also part of the team that co-created and ensured that this data is available for us to share with the province. That will be followed by engagements in the different tables. We have pre-selected how you will be sitting to diversify the discussions to ensure that civil society, government departments, program implementers are sitting together just for us to reflect on the results, but looking at the implication in terms of what is happening in the province. There are questions that are already placed in your table, so the HSRC facilitator will lead those discussions in the tables that are allocated to you. We will also have a working tea break, so you'll just grab whatever that is outside and then come back to continue with the discussions. We have allocated about 45 minutes for these discussions. Then we would ask that when you discuss, you also select a representative for the table that will then just summarize or just give an indication of what was discussed in your table. And obviously, if things are mentioned in table 1, you don't need to repeat them if that's what you also touched on in your table for the sake of time, colleagues. Then after this feedback from the stakeholders, we will have reflections on the presentation and some of the discussions that would have unfolded during the feedback session. And then we have Mr. Richard Shandu from the KZN Civil Society Forum. We have Mr. Jabulani Umdebele from the Department of Health in the province, Dr. Subongiseni Konko from the Department of Education in the province, Ms. Unombisa Zama from the Department of Social Development, and Ms. Tembile Dlamini from the Provincial AIDS Council, as well, who will then provide that feedback. That will then be followed by us closing the activity of the day. So we also have an evaluation form. We hope that this is the beginning of the many conversations that we would have as the HSRC and its partners, as we hope that we'll also receive funding from the colleagues, even maybe from the province, to allow us to do the next survey and then come back to do this feedback session. So it will be helpful that you provide us with feedback in terms of what you liked and what we can improve on if we were to come back again to the province. Then we will, as we prepare to depart, we'll then also have our lunch then. So it also gives colleagues that are have to travel for a long distance time to just have a short lunch and travel. Those that are close by can also use the opportunity to interact with us. We'll have lunch with you to interact more with us and the colleagues that are sitting with you about the findings of the day. So that is our program, colleagues. And then I'm informed that you have completed the questions on the Mentimeter, the 3 questions that we've asked you to complete. So if we can quickly, Mr. Zimande, do you want to just join me as we read through some of the responses from the colleagues? The first one being about what the expectations were for today's event. And do you want to comment? Okay, that is fine. So what we see here is that some colleagues have mentioned that they expect to have an understanding of why so much new infections, new findings. They want to strengthen partnerships. They want to learn about new findings. They want to understand the KZN results, what the latest findings are, to understand what this survey is about, the rate of infections amongst youth, an update on the HIV prevalence, new information on HIV prevalence, and gain insight into the KZN and South Africa HIV status as well. Okay, if we can go to the next question, which looked at the curated gallery. We just want to find out how those images made you feel. We've had or received 27 responses so far, and then it says remembrance of our history. It is still a long journey. We are saddened but hopeful. It took me back. Sad and motivated, hopeful, health inequality. I just felt okay. We see an emoji there. Impressed, grateful with South Africa's strides, sad and proud, sympathetic, emotional, a reminder, nostalgic as well. If we can go to the last one. Okay, so the one thing that you think makes you unique, and you'll realize that as much as we think we are unique, there is some similarities amongst us. We are more. Okay, so one said adaptability. I'm unique because I'm me. Listening skill, dependable, caring and versatile. I'm a hard worker, relationship, calm, willing to learn, goal-driven, gray hair. So, okay, that's what makes the colleague unique with the gray hair. I'm trying to see who has gray hair here so that we can see how okay, and the strategy to prevent, find it easy to converse. And then the other one says, I smile when I'm angry. That's what made them unique as well. Okay, colleagues, without wasting any more time, I would like to welcome Dr. Amy Du Bois, who's the Deputy Director from the Health Systems and Strategy from the CDC South Africa.
Representatives from the KwaZulu-Natal Departments of Health, Education, Social Development, from the Provincial Council for AIDS, representatives of civil society, our colleagues from HSRC, from other government institutions, from institutions of higher learning, from the private sector, our implementing partners, colleagues, ladies and gentlemen, good morning, all protocol observed. It's my great pleasure to be here with you today to congratulate the HSRC and to congratulate the government of South Africa for completing the 6th National HIV Household Survey and for an impressive legacy of leading national HIV surveys in South Africa over the past 20 years. Today's dialogue is the beginning of conversations with the Department of Health and its partners about using SABSSM data to really inform program strategies and planning in KwaZulu-Natal in the future. The SABSSM team is making granular data available on HIV care and treatment and prevention interventions, including data for modeled HIV estimates at the national and provincial and district level that are so important for the Naomi and Tembisa models that we depend on. The findings at the national level are encouraging. They demonstrate that South Africa's policies and programs have contributed to a stabilizing epidemic, to increasing levels of population viral load suppression, and to promising trends in HIV prevalence and incidence, particularly among adolescent girls and young women. The surveys helped us understand where we've made great progress, and that is a wonderful thing. They're also helping us understand which areas really need more focus in the future. With these data, we can strengthen our programs on HIV prevention, including on testing, particularly for men and for youth. These data allow us to target our efforts towards finding and linking people in need of treatment and prevention services. The efforts are even more important in the context of the reality of U equals U, which was launched here in KZN in May. The message of undetectable equals untransmissible is joyous news, and it's a powerful tool in communicating to people living with HIV and those at risk that there's hope, that there are answers, and there's a bright future. By focusing the lens on provincial and district level data, as we'll do today, we can inform programming and strategies to best meet the needs of the communities here. And that's why it's so important that they are all represented here in this group. The U.S. Centers for Disease Control and Prevention, CDC, through PEPFAR, is proud to have collaborated with the HSRC on this important survey. We have provided funding and technical support to HSRC to conduct the SABSSM surveys since 2005, and we are proud of everything that has come from the great partnership. SABSSM is a shining example of local capacity and country-owned data, as well as how investment can build systems and infrastructure needed to respond to current and to future health threats. Once again, congratulations to the HSRC and to all its partners for completing one of the largest HIV surveys worldwide. Congratulations to South Africa as a leader for developing and sustaining a highly capable workforce in science, surveillance, and surveys. This work will truly make a difference. Thank you so much.
Thank you so much, Dr. Amy. Moving along, colleagues, to the presentation by the HSRC and CDC team on the KZN Provincial and District results. I'd like to welcome Professor Kangalani Zuma, who's the overall principal investigator for the SABSSM survey. He will be joined by Mr. Sibonelo Kamani, who is the provincial coordinator and one of our researchers, as well as Sandisi Wegenyu and Dr. Palegia Murangandi from CDC to also share the findings as well. Please welcome the team, colleagues.
Representatives from our government, the government departments, the civil society, our partners here, all protocols observed. Ladies and gentlemen, good morning. Colleagues, it's really a wonderful day and a pleasure for me to be taking you through the results of our HIV prevalence survey. This is the study, colleagues, that HSRC has been organizing, as my colleague Amy has indicated, for a number of years. And this time, as you would have seen, what HSRC is doing is something that we've actually not done before, and we're doing it for the first time, to actually take the results to the lowest level possible, our data permitting, so that we have a conversation about the HIV epidemic, and also ensuring that we really keep the fight against the HIV epidemic, because HIV epidemic has been here with us for almost half a century. But we still have a long way to go. There's still a lot of work that needs to be done in fighting this epidemic. So, colleagues, I'll be taking you through the results, starting just giving you the background of where the study is coming from. A part of it, Amy has already indicated. We get through the main objectives of the study. Why do we organize the study? Why is it so important to have such information? And then we speak about the methods of how the study was designed, so that when we compare the statistics from these results, we also understand the methodology behind how these data were collected. And then we'll take you through the results, obviously focusing specifically to the province of KwaZulu-Natal, but positioning the province, placing the province in relation to where we are as a country and where other provinces are. And then we'll talk about the key biomarkers, related biomarkers, and also the possible key drivers to the epidemic, and some concluding remarks. Colleagues, this is the study that started long time ago, about 2001 or 2002, when the first survey was presented. This study was pioneered by our former president, Dr. Mandela, at the time, and it was implemented at the time when actually being found or testing HIV positive was in a way synonymous to being sentenced to death, for example. But over the years, good work has been done and a lot of intervention have been put in place, and now we can talk about people living long and a healthy life with living with HIV. So the study has expanded in scope in that we've increased the sample size. When we started, we're getting to a sample of households and inviting a sample of people within each household. I think I remember we used to take at most 4 people in each household to participate in the study, but now we've expanded in scope in that when we get to a household, everyone is invited to participate. So furthermore, the study has expanded in that we are no longer only presenting results at national level or provincial level, but we go to the lower level, the districts now. So we've got sufficient data to present this information at district level. And of course, not all districts are included, but a sample of districts, about 33 districts, are part of this survey. So this has been quite a big step in that we can present results at a lower level. And in that way, we're able to actually identify where the problem is. So we're no longer talking about that there is a problem, but we go further and say, where is the problem? So that when we put interventions, we know exactly or almost close to where the problem is. Now, when we get to a household, we're no longer taking a sample, but we invite everyone to participate in the study. So it's a take-all approach. So this information over the years, it has been a major source of information for measuring the progress that we are making in response or in relation to our National Strategic Plan for HIV, STIs, and TB. And HSRC, together with its partner CDC PEPFAR, who worked with us since 2005 and up until today, are part of this study. And for that, again, we're very grateful. We have implemented this survey. This is the 6th time that we're implementing the survey. So every after 3 years, we implement, almost every after 3 years, we implement the survey. So I hope that by the end of this meeting, all of us would be able to convince my colleague from CDC that we do need the next survey. And you know what that means. It means funding that will be needed. Okay. Colleagues, the survey aims to be able to present results at national level, the statistics at national level, as well as at provincial level and at district level. And obviously, as I indicated that we are able to present results at district level. Not all the districts are included, but some districts that were included are the districts where there are PEPFAR programs taking place there. And then also some of the districts, even though there was no PEPFAR program taking place there, they were included as per suggestion from the National Department of Health. As also as indicated, we present results at national level, that's the HIV prevalence, the exposure to ART, indicating the prevalence or the proportions of people that are on antiretroviral treatment. And then also we present statistics about viral load suppression. And the other statistics that we present is the HIV incidence. Now, colleagues, prevalence, just the cumulative number of people living with HIV. So because we know that once a person is infected with HIV, you remain HIV positive. So that gives us the total number of people that are living with HIV at this present point in time. So that is the prevalence. Now, the other statistics of interest is HIV incidence. which is basically a statistic that tells us, if we're to say, if at the beginning of the year, we look at how many people tested HIV negative at the beginning of the year, how many of them would have seroconverted and became HIV positive by the end of the year? So that is the incidence. Now, we are only able to present HIV incidence estimate at national level. The reason being, for us to be able to calculate it precisely, you would need to have many people getting infected with HIV so that you can have sufficient numbers to do calculations. Unfortunately, we don't have those sufficient numbers to be able to do the calculations. And on one hand, then that is good news, because it means we don't have many people getting infected with HIV. So it's good that we can calculate the statistics even at lower level, because it says we don't have as many people getting infected with HIV. But that is why then we're only able to present it at national level. We don't have sufficient numbers of people that are seroconverting. Now, how is this study designed? And of course, colleagues, when we talk about these statistics, we compare. Colleagues would come and say, but we have seen other statistics saying this, other statistics saying that. Why there are so many statistics coming up with different numbers? One thing we need to sort of understand is that different methods that are being used would likely come up with different results or statistics. But one thing for sure is that those statistics would be pointing us to the same direction, would be giving us the impact that the HIV epidemic has had. And also, as my colleague has indicated, that statistics, for example, from a Naomi model, as an example, or from Tembisa model, part of information that goes to that modeling work is actually these statistics. So the survey data is actually used to recalibrate the model statistics. So the models are also partly informed by data such as from surveys such as these surveys. Now, how is this study designed? Again, the study is stratified at provincial level, so we go to all the 9 provinces. So as a starting point, a country is divided into small communities that are called small area layers. There are about just over 84,000 small area layers in the country. And small area layer, it's a geographical area of about 200 to 300 households. And Statistics South Africa actually has that database that we are able to access. And HSRC then randomly select over 2,000 small area layers as a primary sampling unit. And we randomly select sufficient numbers of small area layers in different provinces, obviously according to the population size in each province. And those small area layers are further stratified by districts, meaning that we've got sufficient small area layers that are sampled so that we're able to get sufficient information at district level. So those are the strata, and then also we stratify by geotype. That's your urban area, your rural areas, as well as your farming communities. So once the small area layer is selected, then we go to that sample small area layer. We then randomly select a total of 15 households in each and every one of these small area layers. Then within each household that has been selected, we then invite everyone to participate in the study. So it's a take-all approach. So it's a multi-stage approach in sampling, and it's a cross-sectional population-based survey in that at particular point in time, we go to that particular house, and a person is interviewed once. We don't do any follow-ups, so that's why we say it's a cross-sectional survey. So we use what we call a multi-stage stratified cluster random sample, because in each small area layer, we take a cluster of those households. So again, once we are allowed to conduct an interview in each and every one of these households, people are invited to complete a questionnaire. Once they've completed the questionnaire, they're invited also to provide a blood specimen. So then at analysis stage, we're able to link the questionnaire as well as the specimen from that particular person. And that is why this approach is referred to as the second generation surveillance survey, which has been validated in a number of studies in the country, like this one, for example. We are doing it now for the 6th time after validating it in 5 studies, and there are many other studies that the team has actually implemented in different populations. So all persons in each household living in the country are invited to participate. They form part of the study. They are eligible to participate. And also, all members of the selected household, as I said, were invited to participate. And also, data was collected from January 2022 up to April 2023, so that is why the survey is called SABSSM 2022, because the majority of the data was collected during the period of 2022, year 2022. So the red dot, each red dot there, it's the small area layer, just indicating how the small area layers were distributed across the country. And you can see that in areas that are urban, where there is densely populated areas, we've got a lot more small area layers there. So that just gives us an indication of where our teams actually did travel across the country, and specifically across the province. So, colleagues, once we get to a household, we administer what you call a household questionnaire, which is a questionnaire that also lists the members of the household, and also we collect some information about the household situation. And then once the head of the household has agreed, and we completed the questionnaire, and we've got a household listing, then we approach the individuals in each household, whereby we administer the questionnaire. Among those that are younger than 12 years, there is a specific questionnaire for them, and the parents or a guardian responds to that questionnaire on behalf of the child. But when it comes to collecting a specimen, then we collect specimen from that particular child. And then we've got another questionnaire, which we call a children questionnaire, that's administered among the 12 to 14-year-olds. They respond to that questionnaire themselves. Of course, in that questionnaire, there's some basic questions about sexual behavior. Then we have another very detailed questionnaire, the 15 years and above, which is a very detailed questionnaire asking about knowledge, attitude, and so on related to HIV. We use a dry blood spot to collect specimen using a finger prick among those older than 2 years. Those younger than 2 years, we do a heel prick, and then we do spotting on that dry blood spot, and that is what is taken to the lab for all the biomarkers that we test. And those biomarkers is, one of them is we test if a person is living with HIV, we do an HIV test, and we confirm if a person is truly positive. Then the next test that we do is that for those that have tested HIV positive and they're older than 2 years, we then do an incidence testing where we test whether that person was recently infected or it's a long-term infection. And it is that information that we use statistically to do calculations to estimate our HIV incidence. The next test that we do is that ARV test to test whether a person has been exposed or taking any of the ARVs. And thereafter we do another test, which is a viral load test, where we do a count of the viral load, and that is what we use to determine whether a person is virally suppressed or not, using a cutoff point of 1,000. So if the count is less than 1,000 copies, that person is classified to be virally suppressed. Anything above 1,000, then that person is not virally suppressed. And of course, it would have been nice to actually have even lower cutoff points, but if we're using a dry blood spot, we're only able to determine specifically anything 800 or lower is classified as less than 800. We don't have the specific count, unless if we're using a full blood, then we'd be able to do that. But because using a dry blood spot, we're only able to determine specifically up to a minimum of 800 copies. Now we come to the results. Or should we skip them? Okay. Colleagues, we randomly selected a total number of just over 9,200 visiting points that were approached. And out of these, we found that over 8,000 of them were valid. So it means these were households that had people who were living there. These were not businesses, or these were not business areas or institutions. Now, from the valid household, 78% of the households completed the questionnaire. Okay. Now, this is where our problem begins. Once we get to a household, if the head of the household does not agree or consent that we conduct the study, we actually lose everyone that would have participated in the household. So which means it is very important, colleagues, going forward that we work together in devising or communicating with our communities well about the importance of these surveys. Because if we don't get as many households to participate, we then lose people that could potentially be part of the survey, and we could learn more about information about HIV epidemic in the country. So a response-rated household level of 78% is not too encouraging, and I'm sure we could do better. And I hope going forward, colleagues working together will be able to do better in this. However, what is encouraging, colleagues, is that once or in the households whereby our data collectors were allowed to conduct the survey, the response rate improves. It improves greatly. As you can see that of the 28,830 individuals that were eligible to participate, almost 94% of them were interviewed, so which means they agreed to complete a questionnaire. So you can see that the biggest problem is at household level. Once our teams are allowed to conduct the interviews, our teams are able to encourage people to participate at a response rate of almost 94%. And of course, then when it comes to blood specimen, people are a bit ambivalent about providing blood specimen, and that goes down to about 60.5%. And we need also to work hard to improve that, because without high number or high response rate at a specimen level, then we have challenges. So we need to encourage people to also provide blood specimen. And furthermore, colleagues, you can see that females are more likely to participate, even completing the questionnaire at 94% compared to males at 89.5%. So there's something more that we need to do to get males to also participate in these surveys. It is important that men also participate in the survey. I was really enthused by the results in another province whereby actually for the first time in these surveys, males were more likely to participate than females in that province. Okay. So males need to also be part of the studies. And you can see also when you look at participating or providing a blood specimen, females are more likely to provide a blood specimen compared to males. Females at 65% compared to males at 55.2%. So again, we can begin to see where the gaps are. And just imagine when you are doing calculations that if most of these males who do not participate in this study are males who are more likely to be HIV positive, or are males who know that they are HIV positive and they don't participate in these studies, obviously that then affects the statistics, because it will eventually, we will underestimate HIV prevalence. So it's very important that people participate as much as possible so that we get results that are precise and results that we are able to actually use to prepare and devise interventions that are appropriate. Okay? Now let's come to the statistics about HIV prevalence. The prevalence of HIV in KwaZulu-Natal is 16%. That is the proportion of people living with HIV. And this has gone down from 18% in 2017. Now, this translates to 1.9 million people living with HIV in KwaZulu-Natal, and this has gone down by about 10,000 people living with HIV compared to 2017. But maybe let me explain this thing, colleagues, in understanding what these statistics mean. Now, if we have, like we had, for example, in 2017, we had about 1.9 million people living with HIV, and the prevalence was 18%. We need to understand what actually contributes to these statistics as we move forward to 2022. I'll explain it in this way. Let's just look at the 2017 statistics, the 1.9 million people there, the prevalence of 18%. If those 1.9 million people living with HIV were all on ARVs and were all virally suppressed, taking good care of themselves as we expect, most likely we'll have more children being born HIV negative. When more children are being born HIV negative, the population growth, we have seen in the statistics census data, population has grown. If more children are born HIV negative, our denominator increases, which means the percentage of people living with HIV will actually keep going down. But the absolute numbers of people living with HIV will not change. It will remain the same because the people are on ARVs, taking good care of themselves, not dying. So the fact that the prevalence, the proportion is going down, one, it could be due to the fact that more people are born HIV negative, which is good news. The fact that 1.9 million people that were living with HIV in 2017 are still there today, it's also good news because it means people are living longer on ARVs. So that is what we need to keep in mind, what contributes to these statistics. However, if 500,000 people died from 2017 to 2022, and another 500,000 got infected, we still have the same 1.9 million people. But the problem is, what contributes, what makes those 1.9 million people? Those 1.9 million people would have been made up of 500,000 people who have died and 500,000 would have been infected. And that would not be good news. So colleagues, every time we look at these statistics, we always need to try and understand what contributes to these numbers, okay? So now, let's move on. But maybe we move on, before we move on to these numbers, from these numbers, colleagues, just to bring into context actually, we just checked actually, the population of people in Swaziland is about 1.3 million. That's the population of a country. And the population of Lesotho is about 2.3 million. So which means, in KZN, we've got the number of people living with HIV are more than the population of Swaziland and just less than the population of Lesotho. And these are two countries. So if we do not take good care of people living with HIV in KwaZulu-Natal, we'll be like not taking good care of more than the population of people in Swaziland and not taking good care of people of just fewer than the people of Lesotho. So these are not just the numbers, colleagues. I know Zumas and numbers, it's one thing, but these are not the numbers but these are human beings. Okay. Now, KwaZulu-Natal, the prevalence of HIV has gone down from 18%. Well, let me say nationally, the prevalence in 2017 was 14%, and it has gone down to 12.7%. Now the question is, this decline in the prevalence nationally, is it because people who are living with HIV died and the numbers went down? The answer is no. But the number went down because of population growth, people being born HIV, more likely being born HIV negative. So population increase, then that leads to the proportions going down. But the absolute numbers of people living with HIV would be a different story. Now, obviously, for many years, the prevalence of HIV has been higher in KwaZulu-Natal than in any other province. But now the prevalence in KwaZulu-Natal, now it comes second. But of course, colleagues, we need to interpret this in the context of population and the numbers of people in the province. For example, the prevalence of HIV in Mpumalanga, it's 17.4, is the highest now. And I've been very intrigued by the media reports saying now Mpumalanga has overtaken KwaZulu-Natal, having more people living with HIV than any other province. Well, it's the percentage which is a function of the population size. The absolute numbers of people living with HIV in Mpumalanga is way less than the absolute numbers of people living with HIV in KwaZulu-Natal. So KwaZulu-Natal has the prevalence as in percentages, but in terms of the absolute numbers of people is way more than the numbers in Mpumalanga. We must always keep that in mind. So colleagues, this order is not about the competition, and also colleagues, we always need to remember, it's not about the numbers of people living with HIV in the province, but it's actually about the numbers of people living with HIV that are virally suppressed that we need to put forward. Because a province or a particular area might have the largest number of people living with HIV, but also almost all of them being virally suppressed and not going to transmit the virus. And then on the other hand, we've got an area or a province that has got the smallest number of people living with HIV, but almost all of them not being virally suppressed. So we've got an epidemic that is brewing in that particular area. So we always need to interpret these statistics within context. And at least I can be forgiven. I'm in KZN, I always confuse R and L because in my language, there's no R. So I will be forgiven here. Okay, colleagues, let's look now at the epidemic profile curve, which is now telling us about what is going on within each age group over a period of time. Now, colleagues, here are concerns. If we look at this curve, let's start from here. Among the 0 to 14-year-olds, in 2017, the prevalence was 3.8. Now, first, let's start and say, well, among the 0 to 14-year-olds, most likely, HIV infections among them is from mother to child transmission or other means, but less sexual behavior. So which means if we compare 2017 and 2022, the prevalence has actually gone down, which means we've got slightly fewer children being born HIV positive in 2022 compared to 2017. Do we agree there? We should. Now, let's move on. If you look at this graph, most of the young ones in 15 to 19-year-olds, it has shifted from 2% up to 4.1%, even though it is less than what it was in 2017. But most of the young ones there, the infections there are most likely through sexual behavior, because this is the transition age where they start exploring and being sexually active. Most likely the infections there are due to a transmission through sexual conduct. Now, 15 to 19-year-old, the prevalence is 4.1%, even though it is lower than 5.2 in 2017, but it is still high and it is increasing. Because if you look at the next following age group, 20 to 24, the good news is it's lower than what it was in 2017, but it still shows an increasing curve. So which means among the young ones, younger than 24, the infections, and remember, they were born HIV negative. So which means the infections that they get there are recent infections through sexual behavior that actually we could have prevented if sexual conduct was delayed, if condom use was used, and if most people are virally suppressed, as my colleague indicated, U equals U. If it's undetectable, it's equal to untransmittable. So, which means these infections potentially could have been prevented, but they are there. It's good that it's lower than the 2017 curve, but it's not good that it's still an ongoing epidemic that we could have prevented. Now, colleagues, the whole curve, we would expect that when people live longer with HIV, people not dying, the curve obviously will shift towards the right-hand side because people get old and they live longer with HIV, and that's a stabilized epidemic. And that is what we see, the curve is shifting towards the right-hand side. People live longer with HIV. However, if you look in 2017, the peak was just around 39 to 40, the prevalence being at 39.7. That was the highest point, the peak in HIV prevalence. If there were no new infections and people were living longer with HIV, one would have expected that over time, that peak of 39.7% should shift towards the right-hand side, and it should remain at 39.7% because no one is born old, we're all born young. So it should have shifted, but remained at 39.7% if there were no new infections. But it did shift towards the right-hand side, but unfortunately it also increased the prevalence to 44.5%. So which is an indication that over and above an aging epidemic, there is a potential and a possibility that there are still new infections that did take place over the last 5 years or so of the survey. So, of which these are people who were about 40 to 44 years. They knew, I suppose they knew a lot about HIV. They knew how to prevent HIV infection. They knew that there are ARVs that people should take, but that did not happen. And that's why we have that infection going high up there. That is one of the potential contributions, a possibility that there's been new infections taking place among older people. That again, knowledge that is there, we should have been able to prevent. Now, again, let's look at overall HIV prevalence by age group and gender. Overall, HIV infections among females is, it's known, it's higher among females compared to males. And again, it's because of our biological makeup, high risk of HIV infection from males to females than the other way around. And if you look by age group, you can see that HIV infections actually increase by age group, and most likely because among those that are old, they've been living with HIV for some time and they're on ARVs, so they are still there. Every year we do a survey, they are there because they're on ARVs. So that's again the results or the consequence of a stabilized and aging epidemic. And also, colleagues, rural areas have the highest, like your farms. We found that the highest prevalence of HIV at about 20%, and also females in those areas, the prevalence was very high, followed by urban areas, and the list in rural informal areas, your tribal areas. Now, by district, we see that again, HIV prevalence in Umgungundlovu is actually the highest. So Umgungundlovu is a district that has the highest prevalence, and also colleagues has indicated that not all districts were included. Hopefully going forward, if funding permits, we'll be able to include more districts. And then, so the gray areas there are the districts where we did not have sufficient, or the design was such that these areas were not part of the survey. But you can see the distribution of HIV prevalence. And again, I just want colleagues to keep the map in mind, because we need to look at this in relation to access to ARVs, to check whether the districts that have the highest prevalence, do they also have the highest proportions of people that are on ARVs. Now, let's look at antiretroviral treatment. Okay. The level of access to ARVs has been increasing in the country. Previously, we're at 63.7, and now, as a country, it's 80.9. And KwaZulu-Natal has got the highest proportions of people that are on ARVs at 87.3. So we've got quite a considerable number of people living with HIV, but we also have quite a considerable number of people that are on ARVs. So we are at 87.3. It's the province that has the highest in terms of the proportions of people that are on ARV percentage-wise. So, which means out of every 100 people that are living with HIV in KwaZulu-Natal, almost 87 of them are on ARVs. But again, for me, the issue is, it's about those that are not on ARVs. Because if 87.3% of people are on ARVs, it says to us about 251,000 of people living with HIV in KwaZulu-Natal are not on ARVs. 251,000 or so are not on ARVs. And those people also are less likely to be virally suppressed. So which means the concept of U equals U doesn't hold among them. And we have a responsibility then to identify who those people are, where those people are. We encourage them to get tested, because the unfortunate part, you find that most of them actually don't even know that they are living with HIV, so which means they are likely to transmit the virus to other people in the case of unprotected sexual intercourse. So it's about the people living with HIV being on ARVs, but the important part is that who are the people that you are missing that we need to bring into treatment. Now, again, we see here overall antiretroviral treatment. Again, females are more likely to be on treatment compared to males. Okay. Now let's come to the statistics by age group. Now, you can see that most of the young ones, when they are born HIV positive, they are likely to be on treatment. Okay? That's good. That's what the policy says. But look at those who are 15 to 24-year-olds. And we agree that most of them were born HIV negative, as we've seen in the graph. And they got infected later. But look at the chances of them being on ARVs. Only 58.8% of them are on ARVs. And if you look among the older people, they are more likely to be on ARVs. So immediately you can see that we are missing a lot among those that are age 15 to 24 years of age. And just to tell you, to bring this into context, 121,000 of the 15 to 24-year-olds were living with HIV, if you do the calculations. And of these living with HIV, 45,000 of them were not on treatment. So it's a very big proportion of young children, 15 to 24 years of age, who are living with HIV and they are not on treatment. And again, we'll see what numbers are telling us. Most likely, they also don't know their HIV status. So which means we've got our work cut out to actually get them to know their HIV status and be linked to care. Because if you look at the statistics, less than 60% of them live with HIV and less than 60% of them are on treatment. And that is a concern. Okay. Now, again, if you remember earlier on, I highlighted Umkungundlovu as the district with the highest prevalence of HIV, but it's not the district with the highest proportion of people on ARVs. So there is a mismatch. So we've got a district that has the highest prevalence of HIV, but unfortunately not the highest proportion of people who are on treatment. So obviously it goes without saying that it will not be less likely to be the district with the highest proportion of people that are virally suppressed. So now let's come to viral suppression. Again, overall, the proportions of people that are virally suppressed has been improving in the country as well as in the province. And now, you remember earlier on we said there were about 251,000 people that were not on ARVs. And now when it comes to viral suppression, that's in the province overall, 261,000 of these were not virally suppressed, of people living with HIV were not virally suppressed. So we've got a very big proportion of people that are not on ARVs, and also have almost similar proportion that is not virally suppressed, as expected, because when people are not on ARVs, they are less likely to be virally suppressed. Okay. And these statistics also are concerning among young children, because the fact that they are not on treatment, quite a number of them, then obviously they are less likely to be virally suppressed. As the numbers show, if you look by gender, females are more likely to be virally suppressed than males. But again, if you go back and look by age group, those that are young, you remember that a very high proportion of young ones was on treatment. And the viral suppression, it's at 88.8%. And remember, this is the population viral load, meaning whether you knew your HIV status or not, because we invite you to participate, we test you, you are positive or negative, whether you know or not, you are included in this group. So this is the population viral load. So 88.8% of the 0 to 14 were virally suppressed. And who were the least likely to be virally suppressed are the 15 to 24-year-olds, the ones that were least likely to be on treatment. Okay? So again, colleagues, we have our work cut out to put more efforts among young children, educate them about HIV, get them linked to care, and assist and work with parents, because again, the issues of stigma are still a challenge. Empower the parents to actually assist, disclose HIV status to their children, and assist them to actually be able to handle and deal with a child that is now living with HIV. So that's our responsibility as members of the society and as public health people. Now, again, population viral load. Again, you remember, Mkungundlovu had the highest prevalence of HIV, was not the district that had the highest proportion of people on ARVs, and it goes without saying that it's not the district that has the high, I'm just using it as an example, and it's not the district that has the highest proportion of people who are virally suppressed. So it's all linked. High prevalence of HIV, if it could translate to high proportions of people on ARVs, that would translate to high proportions of people that are virally suppressed. So we can see where we've got gaps, but we're going to get to the gaps in a minute or so soon. Now, my colleague is not here, so which means I have to continue with this part. Okay, colleagues, now let's come to the 95-95-95 target, which is, again, I'm speaking to the converted. It says 95% of people, our target is that 95% of people that are living with HIV should actually know that they are living with HIV. And also, 95% of those people that are living with HIV and they know that they are living with HIV ought to be on treatment. And 95% of those that are living with HIV and are on treatment, they know that they are living with HIV and are on treatment, 95% of them ought to be virally suppressed, and the cutoff point there is indicated is less than 1,000. And of course, in the behavioral surveys, some people, this is a voluntary survey, some people would say, I know my HIV status, and I'm on ARVs, I don't see the need of providing blood specimen. Obviously, we encourage people to participate, we can't force them to participate. So even if people did not provide us with a blood specimen for testing, as we often would want, but if they indicated that they knew their HIV status or they were on ARVs, then we consider them to know that they are living with HIV, so they form part of the first 95. And also people who tested positive when we're doing an ARV test, they are included obviously, but also those who self-reported that they were on ARVs, we also include them in our second 95. And then the third 95, obviously, it's a test. It has to go to the lab. Okay. So where are we as a province? Okay. Even with the gaps that we have highlighted, that we have seen, colleagues, we see that actually a considerable proportion, almost 95, almost there. We've got our one leg in the 95 target. Almost there, 94% of people living with HIV knew their HIV status. And this is really good because as a province, we were like almost there. Okay. The second, among those that are, and again, remember, colleagues, the most important part in dealing with these surveys is that people must know their HIV status, because that's the first step in actually dealing with the HIV epidemic. And then, of those that were aware of their HIV status, 93.4% of them were on ARVs. So unfortunately, we still had guys who knew that they were living with HIV, but they were not on ARVs. So those are people that we really need to get them into treatment. And fortunately, once people are on treatment, they knew their HIV status, again, viral suppression is high up. So we are above 95% once people are on treatment. So it's important that we get people to be on treatment so that we can attain these high levels of viral suppression. And then we are given for free that these people will not transmit the virus to other people. Then in a way, going back, we're dealing with those possible new infections that we seem to be seeing, even without the statistics on incidence, but we seem to be seeing when we looked at that age profile graph that we saw. Now, also again, by age group, you see that the 15 to 24-year-olds are the least likely to know their HIV status. So they are living with HIV, as we've seen. They are less likely to be on treatment, and they're even less likely to know that they are HIV positive. So again, we've got our work cut out there. But once they are put on treatment, the numbers change. They are in the 90s in terms of viral load suppression. So we have to get them on treatment so that we deal with that. And again, it improves in terms of the being on treatment, but not that much. The other age group, the older people, are in the 90s. The young ones are around 88. Now we can just have a look by different districts, colleagues, and we can see most of the districts in terms of awareness are all around the 90s. Some districts such as Utugela, about 97% of people that were living with HIV knew their HIV status. And also this translated to the 97% of them being on ART, so exceeding the first two targets. I'm just picking that one district. But when it comes to viral load suppression, it would have been nice if also it would have been high up there, because would have been great. But unfortunately, it was at about 91.5% in terms of viral suppression. But the first two targets, there were quite high. Okay. Now, in terms of the gaps, colleagues, who are these people that we are missing, and where are they? So we're now looking at among those that are 15 years and above, and saying, among people who are living with HIV, okay, just overall, percentage of people that are living with HIV, 8.5% of them actually are those that are aged 15 to 24 years. And the biggest proportion of them are those that are aged 25 to 49 at 68%. And then 23.2% among those that are older than 50 years. But let's come to those people living with HIV, but who are not aware of their HIV status. So they are living with HIV, but they are not aware that they are living with HIV. 28.4% of them were the youth aged 15 to 24 years. Were living with HIV, and they were not aware that they are living with HIV. The next percentage is those that are 25 to 49-year-olds. Possibly a big part of them would be those males that we missed in the study that did not want to participate in the study. So again, they are 55%. And we still have people aged 50 years and above who are living with HIV, but they don't know that they're living with HIV. The question among those ones, could it be those people that were in that gap who were likely to be new infections from 2017 to 2022? I don't know. But we've got people, 17.4% of people, 17.2 who are not aware that they're living with HIV, but are old. How about people who are aware that they're living with HIV, but they're not on ART? 19.1% of them are children aged 15 to 24 years, 64% of them are those 25 to 49, and 17.4% are those that are 50 years or older. They know that they are living with HIV, but they are not on ART. The next group are those that are living with HIV, are on ART, but not virally suppressed. Again, that's 15.7 among children, 66.4% among those 25 to 49, and almost 18% among older people. They are aware that they are living with HIV, they are on ART, but they are not virally suppressed. So we need to look closer to them also again, because if you are not virally suppressed, we know what that means. And then when you look at which areas actually contribute disproportionately to this population of people that are living with HIV, who are unaware of their HIV status, some of them who are aware but who are not on ART, and some of them are aware they are on ART but they are not virally suppressed. The majority of them are from urban areas, followed by the rural informal areas, and also the least of them are in rural formal areas. Okay. And if you remember, actually, the rural formal areas had the highest proportions, a very high proportion of people that were on ARVs. Now, colleagues, my colleague, Mr. Kamane, will come and talk to us about the key drivers. It seems he has gone now. Oh. Thank you so much, colleague.
Thank you so much, Prof. Good morning, colleagues, and all protocols observed. I am Sibonelo Kamane, a health researcher and SABSSM Provincial Coordinator for KZN, and I'll be taking you through the key drivers of the HIV epidemic with Ms. Sandisiwe Kinu. Okay, so the first key driver is sexual debut, which is defined as having a sexual encounter before the age of 15 amongst those who are 15 years to 24 years of age. So the proportion was 11.2% in 2022, a decrease from 13% in 2017 at the national level. When looking at KZN, sexual debut remained consistently lower than the national average at 8.6 in 2022 and 8.2 in 2017. Okay, when looking at sexual debut by selected demographics, males had the highest prevalence of sexual debut at 12.3%, which was more than 2 times higher compared to females at 4.8%. Sexual debut was also higher amongst residents of urban areas at 10.5 compared to other localities. When stratifying sexual debut by districts, the district with the highest number of sexual debut was eThekwini at 9.4, followed by eThekwini at 8.8. Okay, the second driver is multiple sexual partners. which is defined as having 2 or more sexual partners in the last 12 months, was 8.9% in 2022, which is a decrease from 10.8% in 2017 at the national level. When looking at KZN, multiple sexual partners was 11% in 2022, an increase from 9.4% in 2017. Okay, when looking at multiple sexual partners by sex and age, males had the highest prevalence of multiple sexual partners at 18.6%, which was 5 times higher compared to females at 3.5%. The youth aged 15 to 24 years of age had the highest prevalence of multiple sexual partners compared to other age groups at 16.3%. Okay, so when looking at multiple sexual partners by district and locality, we found that Herikwala residents had the highest prevalence of multiple sexual partners at 14.1%, followed by Umkhanyakude at 12.5%. When looking at the locality types, we found that multiple sexual partners ranged from 12.4% in rural formals to 10% in rural informals. Okay, in terms of condom use during most recent sexual encounter, it was 31.8% in 2022, a decline from 39.0% in 2017 at the national level. And then when looking at KwaZulu-Natal, condom use was 32.8% in 2022, also a decline from 44.9% in 2017. Okay, in terms of consistency of condom use, at the national level, 50.7% of individuals aged 15 years and older reported that they had never used a condom with their most recent sexual partners. That's on a national level. And then when looking at KwaZulu-Natal, the figures are slightly lower at 45.2%. Okay, when stratifying by district, King Cetshwayo had the highest prevalence of individuals who are aged 15 years and older, who never used a condom with their most recent sexual partner, at 52.7%, followed by Umkhanyakude at 50.5%. I will now give Ms. Gino a chance to take you through the rest of the key drivers. Thank you.
Good morning, everyone. My name is Sandy Siwe, and I'll take you through the rest of the key drivers. Okay. So for self-reported circumcision among males aged 15 years and older, the national prevalence went from 60% in 2017 to 63.7% in 2022. And in the province, it went from 60% in 2017 to 63.7% in 2022. And in KZN province, it increased from 38.3% in 2017 to 54.6% in 2022. So when stratified by age, self-reported male circumcision was highest among those between the ages of 25 and 34, as well as between the ages of 15 and 24 years. at 62.8% and 62.6% respectively. And the lowest was amongst those aged 50 years and older at 32.8%. By locality, self-reported male circumcision ranged from 56.5% in urban areas to 51.5% in rural, informal, or tribal areas. By district and age, self-reported circumcision was highest amongst respondents between the ages of 15 and 24 years, residing in uThukela at 79.5%, and it was lowest among those residing in Ugu at 51.6%. So the lowest results were also noted amongst those aged 50 years and older, with Umkhanyakude having the lowest prevalence at 25.3%. For self-reported circumcision type amongst males aged 15 years and older, by province, so nationally, medical circumcision was at 60%, and traditional circumcision was at 39.2%. And in the province, medical circumcision was 87.6%, and traditional circumcision was only 11.8%. When stratified by age and locality type, medical circumcision was highest among those between the ages of 15 to 25 years and ranged between 88 in urban areas and to 85.7 in rural, formal, or farm areas. Traditional circumcision was highest among those 50 years and older at 30.4 and lowest among those aged 15 to 24 years old by age, or of age, sorry, by locality type, and it ranged from 13.7% in rural, formal, or farm areas to 11.6% in urban areas, which is the opposite of medical circumcision. By district, medical circumcision was highest in uThukela at 93.9% and lowest in Herigwala at 58.9%. And the prevalence of traditional circumcision was highest in Herigwala at 39.3% and lowest in Zululand at 6.2%, which is also the opposite of medical circumcision. So overall in the province, for PrEP awareness and uptake, 44.8% of respondents reported that they have heard of PrEP, 6.7% reported that they have taken PrEP, 2.5% reported that they were taking PrEP at the time of the study, and slightly more than a half of the respondents at 63.2% reported that they would take PrEP to prevent HIV. And by district, people who reported that they've heard of PrEP ranged from 52.3% in Zululand to 40.2% in Umkhanyakude. For those who have taken PrEP, the results range from 9.3% in Herigwala to 4.9% in Umkhanyakude. The results for those who are currently taking PrEP range from 4.7% in Herigwala to 2.2% in Umgungundlovu. So willingness to take PrEP was similar across the districts and ranged from 64.6% in Zululand to 55.3% in King Tsotsolo. So a majority of respondents expressed that they would be interested in taking PrEP in the province. For HIV testing, among people aged 15 years and older by age groups, the figures displayed in the screen show the recency of last HIV test for females on top and males at the bottom for each age category. So blue is tested in the past 3 years, yellow is for people that have never tested, and green is for people that have tested more than 3 years ago. And then red is for tested but never received their results. So in the first bar, we see that for the youth aged 15 years to 24 years, 19.8% of females have never been tested. And 72.3% were tested in the past 3 years. And for males, 25.9% 0.5% have never been tested, and 61% tested in the past 3 years. So in the second bar, we see that 83.1% of females and 80% of males aged 25 to 49 years have been tested in the past 3 years. And in the third bar, for both males and female, we see that slightly more than 50% of people aged 50 years and older have been tested in the past 3 years. Now I'll hand over to Dr. Pelagia to do the rest of the presentation.
Good morning, everyone, and all protocol observed. My name is Pelagia Mrangandi from CDC, and I'm going to take you through the few remaining slides. So I'll start with the concluding remarks. So from the results that have just been presented, we see that KZN is among the provinces with highest HIV prevalence nationally, but also the strongest program performance across the clinical cascade and population viral suppression. From the graph that Prof presented, we saw that there was a shift in the HIV epidemic curve towards older age categories, signaling a stabilizing epidemic. We also saw that there are disparities in the burden of HIV, with HIV prevalence approximately threefold higher among young women at 9.8% compared to males 15 to 24 years at 3.3%. And among adults 25 to 49 years, we see a nearly twofold higher HIV prevalence among women at 38.4% compared to males of the same age group. When we look at the ART coverage, there has been a marked increase from 71.2% in 2017 to 87.3% in 2022, but remains low among youth aged 15 to 24 years at 62.8%. There are subpopulations that are overrepresented within gaps in the clinical cascade, and these include adolescents and youth of both sexes aged 15 to 24 years, and people living with HIV in urban areas. And in 2022, prevalence of circumcision among males aged 15 to 49 years was 59.4%, which fell below the national target. However, 87.6% of circumcised men had medical circumcision. And when we look at pre-exposure prophylaxis awareness, it was at 44.8%, and ever use of PrEP was 6.7%, which was universally low across districts. However, it was encouraging to see that willingness to take PrEP was fairly high at 63.2%. So with this, what are the actions that could be considered to take the HIV response forward? A long-term strategy to care for individuals in an HIV epidemic will be beneficial, and heightened focus on campaigns such as U = U and other strategies to promote uptake and sustained use of antiretroviral treatment, especially among young people and adult men, and addressing health inequalities and combining prevention strategies to address specific HIV prevalence and treatment rates of concern at district level, while also enhancing prevention efforts that target groups disproportionately affected by the drivers of HIV infection, such as women and young people. With continued focus on increasing uptake of circumcision among males aged 15 years and older, and enhancing accurate public awareness of effective HIV prevention measures, including regular HIV testing, condom use, and PrEP. So with this, I would like to thank the field workers who spent months in the field. As we saw, it took 15 months to collect the data, and they went up and down in the communities to collect this information. their efforts are greatly appreciated. Thank you. So this work wouldn't be possible without a consortium of partners led by HSRC, and this consortium included US Centers for Disease Control and Prevention, South African Medical Research Council, National Institute for Communicable Diseases, University of Cape Town, National Department of Health, South African National AIDS Council, United Nations Children's Fund, United States Agency for International Development. And the funding source for this survey was President's Emergency Plan for AIDS Relief, PEPFAR, through Centers for Disease Control and Prevention, CDC. We are very grateful for this support. And this work wouldn't have been possible without the contributors from development of the survey, implementation, and reporting stage where we are right now. Thank you.
Thank you so much to the HSRC and CDC team that has presented the findings, and that's it, colleagues. You have now heard it, and it is now time to reflect more in the small groups just on what you've heard. As I've mentioned earlier on, there are HSRC colleagues in the different groups to try and also answer some of the questions that you may have, and also respond to some of the questions that we have, which are also displayed here, to try and guide what we also are discussing. We've also noted a request that instead of having 45 minutes, we allow for an hour for this discussion. So we will just have the discussions for an hour. We can start off, or just to note that if you want, you can, as we discussed, just have a tea that is also available outside, so that those that were not able to take anything in the morning can also take advantage of that. So the colleagues that are online, you will then join us for after an hour, where we'll then have the different groups that are able to reflect on the discussions that took place based on the questions that are offered. So I'm now going to hand over to the facilitators in the different tables to then lead these discussions, colleagues. Thank you.
To cover those districts that were omitted in terms of the report, because we also need to get a clear picture in terms of our province on what is happening in all the corners of our province, not in those certain districts. I think that will be my comment. And again, the report also assisted us to focus more on certain areas, or to look or to pay attention on certain areas of the reports or of the sectors, specifically the youth. I'm happy that the youth sector is here. I think now they realize the amount of work that they, and amount of effort that they need to put on the work that they are doing on the ground, including the men's sector also. because that is another challenge that we have on the side. Since the civil society is here, I'm sure they will be able to also to look at the men's sector and try to improve the work that they are doing on the issues of HIV and AIDS responses. And I must also really appreciate the report, colleagues, and I'm hoping that as we look forward, because not as the province, before the end of our PIP, the provincial PIP, which was ending in 2022, we also conducted our own review in terms of the work that we are doing as well as the impact. So some of the areas that we are touching on, or this report is touching on, it's also, those areas were highlighted by the report or the review report that we have also conducted as the province of KwaZulu-Natal in terms of, and we are in the process now to develop the new PIP, of which is also finalized. Now it's a matter of taking that PIP to the Executive Council for approval, working with different departments. And there are a number of strategies or plans that we are putting in place in order to deal with issues of HIV and AIDS, or all the issues that are societal issues within our province in an integrated approach. And recently we are coming from the session which was coordinated by the Department of Health, where we were dealing with the integrated health promotion. Again, that is another a system that we are putting in place to provide a comprehensive health to our citizens in the province of KwaZulu-Natal, which was led by Obabu Mndebele. I'm sure during his reflection, he will also cover those areas, and just to give highlights so you can also understand the amount of work that we are putting when it comes to issues of health within our province of KwaZulu-Natal. I think our colleagues with those words will go straight to tables in terms of giving us the responses. Fortunately, I'll start with table number 1, or rather call this table by name because there are names on the table where colleagues will be able to reflect on the reports based on the question that were posed there. And I'll request that colleagues will introduce themselves and also stand up. I'll request that you stand up, colleagues, so you can be able to or seen on the cameras, because there are also colleagues on the because there are colleagues that are on the virtual platform, so they must be able to see the person that will be talking. It's not about the camera per se, but it's about the people that are on a virtual platform. Okay, group number 1. Do we have a roving mic? There is table number 1 there. Fortunately, it's my group. Okay, do you have a roving mic? Can you please hand over a roving mic to Uzonke? Usisi Uzonke will give us the presentation on behalf of that group.
Okay, igama lami uZonke Wangandlovu. I'm coming from the PHIV sector in the province. I'm lucky enough to start today. All right. From the presentation that was presented here today, our discussion were what are the lessons learned in the province from what was presented. The data is not something new to us. It's something that we needed to make sure that all our campaigns are structured around data-proven interventions that are happening. And we saw that there is a need for a comprehensive health package that needs to be implemented in the province. It's there in some of the districts, but in others, it needs to be strengthened. Also, when I'm talking about comprehensive health package, it also should include NCDs, which fits in perfectly with the health promotion strategy that our chief director just told us about. When we look at the data, we're also we asked the question about the questionnaire that was used, especially in terms of the multi-partners data that was presented. Also looking at the stigma that is associated when a woman has multi-partners, being the name calling versus the men when they have multi-partners, they are praised. So we also talked on that, saying, is it a true reflection, or maybe some of the women were scared that they will be labeled if they say that they have multi-partners. So in terms of the communication around where do you and your children or community learn about HIV? In terms of the communication around HIV, we have programs in the province, like the LSA program, the Learner Support Agency programs that are running in our schools, in some of our schools, because not all schools have the learner support agencies. And we also have programs that are run by DSD, like Ochomi, Aboyolo, programs that are running by our partners, like your Dreams programs. And we also have skills programs that are run in line with the Dreams program, like the one that are done by OTP and HIV Care, where people go in and they are skilled. The young people go in and they are skills. And we also have support groups and adherence clubs for people living with HIV. I think one of the gaps there was that when they do have those support groups and adherence clubs, also a comprehensive care package needs to be there, where when I go for a support group meeting, I also get my medication and I also do my bloods if I'm due for bloods. We do have a program with CCMDD, which assists in the queues in the clinic if people are decanted and then taken out of the facility to fetch medication outside. We also have community dialogues, which are done by different civil society departments, everyone that are running within the community. But we do have gaps. Gaps in terms of disclosure. We still have a problem with the disclosure issue, especially to children. We don't have like a standardized program for disclosure. So everyone is doing, in some areas, children find out for themselves that they are HIV positive, and that contributes to them dropping out of care. We also have issue of HIV taking a backseat due to a number of things. We don't hear about HIV in TVs, commercials anymore. We've had things that have been happening in the country that has made HIV conversation take a backseat, like your COVID, the floods. We recently had the snow. So there are so many things that are happening, and colleagues, I wish we could have a robust communication strategy, just the same way we had with COVID, where we'll have messaging coming in your phone about HIV knowledge. People don't even know how transmission is happening at the moment in the community. So we really need to go back to basics and start doing treatment literacy classes with the community. People don't even know how to use a condom. We are saying condom usage has declined, but people don't even know how to use a condom. So how can they use a condom when they don't know? I don't even want to talk about female condoms. We also do have things that have been happening which are good in the province. and which we think that we should take pride in. We've just recently developed the health promotion strategy, which last week our colleagues from Eastern Cape came and benchmarked from us. So I think that is good for us as a province. We also developed the PIP. It's in the last stages. So those are the things that we should take pride in. We are in the process of developing the teenage pregnancy strategy. We also have the Global Alliance, which was launched here in KZN. We also have Uzikhala Kanjani from the youth, which are strategies that are working and we should take pride in. We also have AYP programs now, which not focus. Remember last time we were focusing more on HUIW. Now we are focusing on both men and women, young men and young women, which is something that we should take pride in. We also have programs for men. Your Isbaya Samadota, your Mina campaign, Kosomba Lamachita, those programs, we should really strengthen them and make sure that men, the communication around it, it's known. In some clinics, they even have AP hour for men, where they can just come in that hour and not hold any queue and just go in and be seen. We also have a coordination structure that is working in the province. We are being coordinated at the Office of the Premier. In the districts, it's the mayor's office, but also within the programs that we do, we just recently learned that we started mapping partners. We do have a tool to map partners so that we know who's who and what they are doing and where they are doing it, so that we understand. Also the MOU with the departments, the reporting, the coordinating meetings, and the quarterly reviews that we usually have. It's something that we need to focus on. One last thing, I would have loved to see what's the data look like at those districts that are not PEPFAR funded or Global Fund funded. And then we do the comparison and see where they are partners, how it is, and where they are not, how the data looks like. Thank you very much.
That is my group, colleague. You must take note of that. That is my group. Okay, thank you very much, Zonke, with the presentation. Colleagues, let's go to table number 2. And yeah, maybe I didn't say earlier on, you will get 5 minutes at least to present. And I'm hoping, colleagues, yeah, we also have covered a number of things from table 1. Then the rest of the group will be 5 minutes each group, and colleagues are requested to be economical with time and wait. Okay, group number 2.
Good afternoon, everyone. I am Silingen Ngobo from UKZN, and I'm representing Group 2, so everything that I'll be saying would be coming from the group. So we are doing question number 2, which is on HIV messaging and to whom it should be targeted at. Basically, it's all your young women, age 15 to 24, young people, basically. What did we say? Where are we going to get these people? Firstly, we had to identify where are they located, and we said mainly they are located at school. Before school, they are located at home, they are located at school, and then universities. So that should be our focus of our whatever interventions that we're going to be doing. So empowering of young women is our first point. And how are we going to do it? It's through engagement at schools and educational institutions, as schools are one of the primary points of access of young people aged between 15 and 24. However, it was highlighted in our table that the policies that are currently in place, especially the Department of Education, is not in line with what the Department of Health really wants. So there is disharmony or mismatch. So which makes it very difficult for external programs to engage directly with the students. We need more collaborative efforts between the different departments, such as your education and some NGOs, in order to streamline access to the environment. Number 2, we said engagement with TVET and universities. I think it's very important because I think with the data that was presented here, we did see that urban areas, and we saw that most universities as well as your TVETs, they are found in the urban areas, and that's where you get high prevalence. So young adults who have moved beyond basic schooling, they offer critical point of engagement. So targeting your first year students is very, very critical. And also creating mentorship program, peer mentors and stuff also helps, so that the message should be the same. And we also highlighted that the message that they find at TVET or at school, it should actually start at home, because primary socialization starts from home, so that the same education problem or same education program or same messages is sustained throughout, and that makes an impact. Number 3, we also said, where is this child or where is this 15 to 24 coming from? They're coming from the community, and in the communities, where do you find them? You find them in churches, you find them in taverns, you find them in social events. So it's also very important that we engage community-based organization in terms of engagement, so that we can find these people. So if the church program, the taverns and social events can actually infuse the same HIV messaging, which is very critical. Engaging young people in these communities is very essential. Venues like the ones that have been mentioned, they provide informal settings, and normally education takes very effective if it's not structured at times, and especially if it's even the mentors that you employ, if there can be of the similar age, then it becomes very effective than finding an older person. Number 4, we said highlighting positive role models. I think all of us, we need role models in one stage or the other. I'm trying to move because we printed the slides. I mean, we did the slides in the limited time that we're given. So, highlighting positive role models, it is very critical so that young girls can be celebrated. In most cases, we celebrate the girls that actually have overcome the adversaries and odds, and the focus has always been on those who have actually fallen pregnant and how they made it. So we said now it's very important to engage those who have never been who have never been engaged, so that they can they can be a good motivation for those who haven't been exposed. So their stories can be an inspirational on others to delay pregnancy and prioritize education and health. Home-based interventions and parental involvement is critical, because we did say it's part of primary socialization, and parents should play an active role in sex education, and provide accurate information and creating open channels of communication in issues like pregnancy, sexually transmitted infections, and HIV. So, and we understand in certain cultures, you only speak to them if you are in trouble. So that also needs to be challenged or changed. And developing recreational facilities, it has been proven that if you keep them engaged and involved, then they will not be have time. Actually, someone said you must make sure that they finish school at 6, and then by the time they go home, they are so tired, they won't have time to engage in other activities. So creating facilities that can create, that can create hubs for health and educational outreach programs, and helping to keep young away from high-risk behaviors. Number 7, we've got a lot of points. Number 7, it's sex education for young males. I think the previous speaker did mention that we're not only now focusing on females or girl child, it's also male child, so I don't have to elaborate more, because we even said in the table, she can't fall pregnant alone, or she can't get HIV alone, so the focus should also be on both genders. Sex education for young males. Am I repeating myself? Yeah. Behavior and versus expectations, which is our number 8. There's often high expectations for young people, but their behaviors do not always align with these standards. I think it also has to do with the role models, because you preach and you ask them to do something else, but they will actually model what you do. So there's this connect. This connect highlights the need for practical, real-world strategies that resonate with the challenges that youth of today face, particularly regarding sexual health and decision-making. And we did highlight that in this era, they are so much exposed to sex, whether it's social media, something just pops in, even if it was not intentional. So, and early intervention strategies, proactive strategies are needed to address sexual health and well-being before risky behaviors take root. We said initiate initiatives like delaying sexual debut and promoting testing for STIs can help identify potential issues early, giving youth the tool they need to make healthier decisions. Number 10, we love this and we debated on this. It was on purity culture and its implication. And somebody in the group said he was actually at Umhlanga. So he really advocates, he feels strongly about Umhlanga, and which is a very good culture of preserving purity. So while purity culture can delay sexual activity, it can also lead to risky alternatives, such as engaging in other forms of sex to preserve vaginal purity. Programs that promote sexual abstinence need to be balanced, inclusive of both genders, and ensuring that they prioritize comprehensive sexual education over mere avoidance. So we also highlighted that as much as people need to be virgins and everything, we should also capacitate them on other forms of sexual behaviors, which we have seen. And number 11, which is career pathing, is also very important because they become very focused. And I think it links with having role models, because sometimes if you've never seen someone, you really don't know, and you find that you are limited with your choices.
As I sum
up, we will discuss the importance of role models. We did say we should identify and support role models. And we did say that these role models, they need to be applicable or appealing to the young people. And we said the departments, they also need to be on social media, TikTok accounts, so that they can actually be followed, and because that is what the youth is on. And also, they should be accountable, these role models, and we did mention some of the role models that are available in the clinical settings, as well as the power of influencers, and which is important. And also with that, role models from different departments is also very important, because you can't make it on your own. So we said departmental collaboration is very important, and champions, appointing of our champions. I think the first speaker also mentioned something about champions, so we don't have to repeat. And also, we also highlighted on what challenges they've had, because I think the director was actually mentioning that they've had champions for pregnancy champion, but each year, whatever champion that they employ, they actually fall pregnant. So we also looked at strategies that can actually help. And then I think my last point will be on U equals U. Is it successful? We said no, it's not. It hasn't been successful. And mainly we said it's because there's challenges with the implementation, especially with the staffing. You find that people don't really have time, and even for education and stuff. I think I will, is my 5 minutes up?
Exhausted.
Thank you.
Thank you very much, Group 2. And Group 2 were responding on HIV messaging that is critically to be communicated and to whom. Group number 3. Yeah, because we are responding on strengthening what needs to be strengthened in the province.
Yeah, kuningi kodwa ke sekumentioned, and I'll be very
Just
economic with
summarize.
time. So number 3, that we're focusing on what needs further strengthening in the province or district program. A was what has been the results for voluntary medical male circumcision VMMC programs. So we said that according to the report, there has been an increase in intake of VMMC, where we saw a rise from 38.3% to 54%. And then we had said that probably it is the interventions that are already existing working. So we need to further strengthen those interventions and funding to support those interventions, like your right to care that is within the province. For VMMC, we have platforms like Isibaya Samadoda, Philandoda, Boys to Men, Men Championing Change, and so forth. And we need to revive the 3-day VMMC camps and make sure that these are at least led, or we have champions eziba izinduna and amakhosi, because we saw ukuthi there's still a low uptake when it comes to rural areas. So if you are having izinduna or traditional leadership also championing this, it will work or further work. And then UP, we spoke about youth interventions and if they have worked. So we have said not entirely. Based on the study, we saw that 15 to 19, there was a low condom use, PrEP uptake, testing, and so forth. So, but we have also said that in KZN, or there is intervention here, AYFS, that is there, but not really entirely youth-friendly. So we need to strengthen that one and focus on Uzikhala Kanjani strategy that has been alluded to as well, because we have seen Uguti, it's working, and it is led by young people, because young people are a solution to their own challenges. So we need to strengthen such campaigns and capacitate young leaders to be able to take charge of their lives and disseminate information and data that is correct, and create void demand creation strategies. And then we also have our PAP that is also youth focused. Yeah, and then C have the prevention strategies for men being successful. We had said not entirely again. And then I think that speaks to VMMC also, points that I have mentioned, but we had said we need to strengthen the men targeted interventions, including the men's and boys' parliaments programs. But what is more important is that we have one point of coordination, because we've seen some programs that are done by DSD, some are done by DOH, some are done by civil society, and so forth. So we need one point of coordination at a provincial level. We can have Office of the Premier coordinating those, and then at district levels, we can have the Mayor's Office also coordinating those. And most importantly, continue to have those dialogues with men and still have the traditional leadership championing those, because KZN is mostly rural and traditional leadership is very valuable. And to get buy-in yamadoda, we need to use the traditional leadership, because amadoda tend to lean more on the traditional leadership. Thank you. And that was group 3, and my name is Boisiwe Khumalo.
Thank you very much. Group 3, I think we are happy with the responses. Group number 4, on successes and challenges in reaching youth, women, and other population.
Thank you, Paga Madlwati, on behalf of Group 4. In Group 4, when we looked at how do we influence the changing patterns and the prevalence, one of the things that we look at, one is that we need to address the social determinants of health. We need to look at gender inequality. I think some of the colleagues have spoken to the issues of men, young boys and young girls. We have concentrated more on the young girls. And also issues of poverty, economic empowerment, and access to education for these young people. And also as we look at this, how do we access, are we looking at the key populations? Are we concentrating on people with disabilities? People with disabilities, we do not have programs that work with them, where we work with them, and yet it has been discovered that we get a lot of them that come, they've been abused, but if they come to the health facility seeking health assistance, we tend to shy away and not be assisting them. And also our education strategies, they should be talking to the age groups that we are talking to. You cannot be saying the same information the same way to the different age groups. Also, when it comes to the education, we said that it should start as young as in primary school. We should not wait for the young children to be sexually active before we can talk about sex education. And it must start at home. Family must be involved. Because what we have also discovered was that some of these children are born to teenage mothers who will not even have the time. How do we then rope in the family structure? And then also, as we do the education, we must be innovative, use edutainment strategies for the age group that we are looking at. And also, we need the social media. The youth access social media. I think one of the colleagues said, where do you find the youth? You find them at school, you find them in taverns, and you also find them in social media. They are very active there. But where do you find us? We are on social media, but do we do anything about whatever myths are being spread on the social media? Nothing. We do not do anything. So that's where we need to leverage on what is already there, the social media, and go in there, play our part as the different structures. And also, when we do health education or health awareness, we need to integrate. A person coming to a health facility for hypertension, you don't end there. You treat the person holistically, look at other issues that are there at home, and integrate everything that is there. You don't deal with what the person is telling you, because we know, we have seen that when people come to the health facility, they will look at you and see whether can I say this or not, looking at your facial structure. If you are smiling or you're not smiling, they will then decide what to tell you and what not to tell you. They might come in wanting to do an HIV test, but because of how you treat them, then they will go out and say, no, actually I've got a headache. And then they go out. And you will not even probe. And then, so basically that's what we were looking at to say is how we influence the changing patterns. We need to do that. And then looking at better coordination of health interventions, it starts at mapping in the community level. All the organizations that are working in the community level, We map them, we know what is available and where, and we integrate all the efforts. We must not be doing and duplicating the same thing in the same area. Look at what is being provided by organization one, what is not being provided, and look at the gaps and fill in the gaps to make sure that everything is being covered. We must have multi-sectoral involvement as well. Churches must be involved. Some said, as we were discussing, that we always concentrate on hallelujahs. Once you say amen, something else starts. Then that's where we need to come in as churches. Traditional leadership. We know that from the engagements that we have had, most of us in our areas about HIV, teenage pregnancy, it's issues that are there where we know that traditional leadership can come in, where they would say people to say before you get married you must have a child so that your future husband knows that you can get children, and in that means that's unprotected sex, and that's HIV transmission without you knowing the HIV status of the other person.
As you round up.
And that was 2 minutes. Okay. Okay. HIV testing awareness and ART, how it is in our communities. We say that there's still a lot of myths that are there. Yes, there are people that have some information, but there is still a lot of myths that are there. There are, where we were talking the issues of VMMC, and we were talking about U equal to U. Yes, they would have some information about those programs, but there are myths that are there. So we need to go in there and look at those myths and intervene as the different departments. And there's still non-disclosure. And especially when we saw the young ones, the teenagers, you would find that they grew up taking these ARVs not knowing what it is, and probably that's the reason why we see a lot of them unsuppressed, because they would stop because there's non-disclosure, and also even at home there's non-disclosure. So we need to focus on reducing stigma and also deal with mental health support for people that are living with HIV, because there's quite a lot of mental health issues that we are not looking into. So basically, what we're saying is that we need to dismantle the myths that are there. We need to use the opportunities that are there, social media, education, integration with everyone, including the community leadership, and have the local peers that role models. It must be people that are local, known to the children in our areas, and and education that starts at a very young age and not wait for children to be old, and it must also be family oriented. Thank you.
Thank you very much. Table, let's give a round of applause. Table number 4. Sorry, number 5.
Thank you. My name is Lutando Zuma. I am from Africa Health Research Institute. So Usis Zonke has said it all.
So that means you have 1 minute.
All right, but I'm just going to add on what has been mentioned already. So we are sharing the very same question with Group 1. So my group has mentioned that on the first question, A, on the implications, we have seen a shift towards a younger generation, to be more specific, from the age of 15 to 24 years, and also from those who are 40 years and above. Hence why we feel like in order to respond to these issues, we have to respond with some targeted interventions. We also felt like it would be ideal to focus more on economic empowerment, especially for the younger generation. I mean, we all know the issues of blessers who are taking advantage of young girls because they are vulnerable. They are, the issues of poverty, especially at the university levels and also, the young ones in high schools. There's a lot of pressure there. Young girls, they like, flashy lifestyle, the iPhones and also hairs and other things as well. So if we can also like empower them in as far as, ensuring that they are empowered in the economy, maybe we can see a decline in the HIV incidence from in our province. Also, we also feel like we should also respond and strengthen the prevention interventions within like cultural areas, schools, recreational centers, and also invest more on behavioral change. And also we can just do a research on that one. Probably we will also, learn the contributing factors towards that, and also be able to respond positively with the necessary interventions. So moving on to point B, where do we learn about HIV? So social media is one of the platforms where most of the information is flowing around, especially the youth or the younger generation. I myself have seen a lot of people who are living with HIV, especially the younger generation, sharing their stories and how do they copy with their HIV status, and also the acceptance and the issues of stigma. So social media has also played a very important role in as far as giving out the information. And I've seen a lot of research institutes as well. My research institute, Africa Health Research Institute, has also taken advantage of using social media to actually target the younger generation. But it's not only the younger generation. I've seen a lot of senior citizens, if I can put it that way. They are also like very much involved, and they really like TikTok, of which in some research organizations have also created like the page to disseminate information on TikTok, Facebook as well, and also other other social media platforms like Twitter as well. So there's a lot of programs on sexual education that are also going around in schools and also in the communities as well. There are also locally based NPOs who are doing a lot of awareness and also health education. So that's one of the means or the platforms of disseminating or giving out information about HIV. And well, this one was very new to me. Maybe it's because I'm not really a church person, but Mr. Kwenza here, he shared that there are some other churches who are, opted for health education, so where they invite health professionals, the nurses, to actually teach and give out the information about health, inclusive of HIV and other diseases and other public health issues that are around in our province, probably around our nation as well. We have seen a lot of NPOs, NGOs, health government institutes or departments acknowledging the calendar days like the World AIDS Day, where they give information to a much more larger population about HIV. And we have seen a lot of people, like HIV activists, being invited there to share their stories and also to encourage people and give supports to a much larger population. And also the dialogues, community dialogues, where it's open, we get information from the population, and also we bring in the researchers, the health practitioners, have this open dialogue to share information and learn from each other. The road shows as well are also other means. And there's something called Condom Week, of which is part of the calendar day. That's the other thing as well. And also tertiaries like universities, we also, use that as well.
As we are rounding up.
Okay.
You said the group one covered everything, but now we are...
Yeah, hence why I'm trying to go through what's probably they didn't mention. And the family disclosure. We learn a lot from family members who are disclosing their HIV status to us, and also, learn on how, like, they got it and how they are coping with the issues of HIV. Moving on to C, the prevention strategies. We said no, not yet at least, but we've seen a lot of efforts on it to actually get more men involved in the issues of HIV. But so far, we still have a long way to go. Hence why we feel like the health facilities mostly are not really conducive for men. Hence why men, they don't really access health care. But we have seen a lot of efforts on Isibaya Samadoda, which has a potential of drawing more men and getting more information from men as well. And we feel like this program should be strengthened. We should invest more resources on it. And also the communication strategies, we should also learn about the communication strategies depending on the geographic area. We should learn the norms, the culture, the practices, so that we can be able to bring a research or interventions that speaks to the need of that community in particular. So that's why we need to review these strategies and also collaborate with traditional healers, take a multi-departmental approach where everybody comes in and bring in their ideas so that we can be able to co-create. I mean, like even World Health Organization is encouraging that. So I think that's it from me. Thank you very much.
Okay, table number 6. I hope table number 6 will cover those critical issues that are not yet being mentioned here, so to avoid any redundant.
Thank you, Chair. Good afternoon, colleagues. As this table, we're focusing on what HIV messaging is critical to communicate and to whom, the same as that other group. We'll just pick the things that they have not mentioned. We said young girls, and then we said we need to focus on emotional intelligence. Girls must be able to handle the comments when they are given some kind of recognition on the street. They must be able to handle that. They mustn't misinterpret that as the sign of care. Also, vetting people. Before you get in a relationship, you must vet a person. Okay. Young girls also need to be able to set boundaries. Very, very critical. And also they must be part of the girls' club. Young girls must be defined by their goals, not by the compliments they get. Okay. We said also when it comes to parenting, we need to have a package for the Youth Month and the Men's Month as well as the Women's Month. The parent-child communication. We need to have parents engaging with their boys, also with their girls. And we also need to empower boys also with emotional intelligence skills so that after circumcising, they must not be chasing girls around just now because they've circumcised. Can you help me to move? Colleagues, we said that the branding is very important. We need to send our messages. Public entities must be used as a way to convey the messages, meaning your government cars, university transport, the community halls, the billboards. We need to put there our message about the pandemic as well, also about you is equal to you. We said they are mostly found in taverns. Most of the people have mentioned that. We said also we need to empower them to manage FOMO because they normally have a challenge, the fear of missing out. We need to empower them to have the joy or the joy of missing out in some other things. Okay, what else? We said it has been successful. You is equal to you has been successful as we are noting the viral suppressed percent in terms of the KZN. But we said we need to expand and have district road shows because it was launched at the provincial levels. Also, we've got non-PEFA district, of which they are kind of isolated. We said in that we need to adopt, a PEFA district must adopt a non-PEFA district. Because anyway in the province we've got about 3 non-PEFA districts. Like Ilembe is in between the 2 PEFA districts, Durban and KC. So if they can adopt, then they will be able also to apply those. We said also in terms of messaging, we need to have something like a quiz. When you want to log on to a public Wi-Fi, you must have a quiz before you can actually log in. So if you can attach a message there, a quiz, so that by the time the person wants to log in, he should have answered those questions, the health check questions. And then what else? Okay. Yeah, we said also the information, we encouraging that there should be an updated information across the board, because normally you'll find that in some areas or in universities, you'll find that the information that is being shared there is an outdated information sometimes. So we need to ensure that we disseminate the current information and also involve universities in terms of empowering the young people on campus, as well as also use also social gathering as part of. We even went to an extent of saying we need to have messages in toilets. When a person is seated there behind the door, there must be something like that the person will read, because he's forced to read anyway because it's there. Let's move. We said, colleagues, we need to integrate our immigrant population. Colleagues, we are only focusing to locals, but also we are leaving behind our people from other countries. We need to work with their ambassadors in terms of trying to integrate them in this information sharing. We also talked about the welcoming environment in clinics. It is very important. They said love conquers all. Like when people feel loved by the health institutions, it will be easy for them to go there. So let's spread the message of love. And then I think it ends there. Thank you.
Thank you very much. Table number 7.
Okay, I'm Sandile Zungu from Department of Education. Thank you.
Okay. Thank you very much. Please, colleagues, introduce yourself before you present. I was hoping that someone will present there, because my mom says I still need to do my reflection, but it's fine. Yes, no, continue.
All right, no, thank you. Thank you, Chairperson. I am Nelson Mzizi from Department of Social Development, Provincial Office. We had focused at a questionnaire as a group based on the results of voluntary medical male circumcisions, meaning the VMS programs. VMSC program. We had said as KZN province, we had been able to achieve and see a reduction on HIV prevalence as a result of the institutional mechanisms and stakeholder engagement, including accountability by reporting at the provincial, districts, and local levels, whereby we had put in the systems as KZN province in terms of the program implementation. And again, you have shown coordination and inclusive services program implementation through Operation Sukumasake, as well as through the district development model, whereby our key leaders are chairing such meetings, and each government sector and the department, as well as the social partner, are reporting in terms of the implementation of programs. And we have ensured that we've got traditional VMSC coordinators mobilizing at all the different communities. We have implemented the community-based prevention programs, including the Resiha programs amongst the adolescents, and the youth, whereby we have shown a provision of psychosocial support services among the young boys as well as men. And we've also had implementation of Isbaya Samatrota, which I won't repeat of how it's done because other groups have focused on it. We have shown a multi-sectoral partnership, assisting in reducing in partnership through the PCA, and then the district development model, which is the baby of the operation Sukuma Sake, where there's been integration at what level? Up to the provincial level. And in terms of the youth prevention, youth HIV prevention strategies, there are youth-led programs across all the government sectors as well as social partners, utilizing the youth KZN development strategy as well as the integrated health promotion and wellness strategy. We have seen more collaboration and coordination of programs like Zikhala Ganjani, implementation of social and behavior change programs, the CHOMI programs, the YOLO, Men and Boys Championing Change program, including the community capacity enhancement programs. We have seen adolescent youth-friendly services as well as youth clubs. We had ensured implementation of youth dialogues and also youth academy placement of youth, and also implementation of youth campaigns and e-youth and Ikosomba Lamachita. In terms of HIV prevention strategies for men, whether it has been successful, we could say that partly it has been successful, whereby you have implemented models looking at physical, behavioral, psychological health programs. However, we need to improve on the implementation of the socio-ecological model, especially when we look at the HIV prevalence amongst the 15-year to 24-year females in comparison with the 50 to 55 among males, and looking at the demographics whereby Umkungundlovu district as well as Herikwala, we have seen a lot of multi-sexual partners, considering the migration labor and also economic programs, which we need to do the research as well as devise some programs which are going to look at the borders, whereby there's some migration, people coming from Lesotho, from Underberg, and then around Kokstad coming from Eastern Cape for economic and job economic opportunities. And other strategies that we're implementing in KZN, where we've seen some successful stories, it's the Nomkhubulwane traditional programs, that is virginity testings, which has reduced the sexual debut among young girls. And then we've got men's happy hour and men's clinic at facilities, also mobile clinics. We've got traditional rock programs as well as religious leadership programs, which then amongst this program, we should strengthen a pastor's wife programs, because that's where things are happening in the churches, amongst overnight vigils, among traditional as well as prominent leaders in church. And we need to improve the best practices like collaboration, coordination of program implementation. And since we have identified the ecological approach in terms of identification of hotspot areas, we need to improve in terms of research, in terms of the socio-ecological model. What are the causal roots of the multi-sexual partnership in the district, whereby we have identified HIV prevalence and non-taking of treatment? And then we need to strengthen the qualitative program instead of the quantitative approach that we have seen for quite some decade, that most of the time we are talking of numbers Hence, monitoring and evaluation of these programs in terms of the outcome of the qualitative approach, we are not seem to be achieving. Results being there's a
As you
high
sum up,
as a sum up, as a sum up, we need also to transform as social partners and the government departments in terms of the working hours, whereby we also consider the happy hour on the digital platform, whereby our colleagues we need also to have employees that are going on social media, the TikTok, and providing our awareness campaign. You know, the 12, the happy hour whereby our children get the free hour and they access all these sexual risky behaviors. And also there needs to be differentiation between teenage pregnancy and statutory rape and voluntary or involuntary ukutwala, instead of speaking of this big terminology, we should say teenage pregnancy. There needs to be research done on the statutory rape, voluntary or involuntary ukutwala, which results into the terminology which is say teenage pregnancy. And lastly, there needs to be monitoring and evaluation amongst all the programs that has been implemented and it's currently implemented, especially in those districts where we've seen oversaturation of program funding. King Letrayo and Mkungundlovu. Thank you.
thank you. Table number 8.
Sanibona. Hayi siyaphila siyathemba niyaphila igama uNtokozo wakatono, chairperson of the provincial youth sector. So we were doing number 4, looking at the successes, challenges in reaching youth, women, and other key populations. So the first question is, how do we influence changing patterns of prevalence among adolescent girls and young women? So here, when we were looking at this question, we felt that majority of the problems that young women and adolescents face actually stem from a lack of proper parental guidance. So Sati, as we need to go back and really look at reviving the family structure to ensure that there is proper guidance of young people, because when an adolescent or a young person experiences certain changes in their body, it actually manifests, and they need to be someone who's actually going to help them understand what's going on, and also how do you protect yourself. And then we also said that we need to have value-based interventions. We need to actually look at the root causes of the problems that young people are facing. We need to target men. So we really need to have more interventions that target abantu besilisa to ensure that they know how to treat a woman or a young person. We also said that we need to go to hotspots, we need to go to where men are, we need to go to taxi ranks, we need to go to churches, we need to really advocate for the interest of young women and girls. And also we said that we also need to involve young boys and adolescent boys in these programs, because it is not really helpful to actually empower a young woman but not really doing anything about the already empowered boy who is empowered by patriarchy in our society. And then we also said we need to have interventions or peer-to-peer, because young people find it easy to talk to each other. And then the second question is, how do we better coordinate efforts on health intervention strategies at local levels? So here we said that first we need to have interventions that are community driven. So we need to have communities taking control of their health and their healthcare system. We need to have them tell us what is it that they want to see kuma clinics, because the interventions are there, but if they're not really taking advantage of the interventions that are there, then it means there's a problem. So we need to go back to the community and say, how do we really help you? We said we need to have a multi-stakeholder approach to healthcare. We identify the fact that the healthcare issues is not a burden of the Department of Health alone. Other departments and other partners also need to chip in, because majority of the issues that we battle with when it comes to health are about behavior change. So we really need everyone to play their part. And then in terms of how is HIV testing and status awareness, art, and viral suppression seen in your community? So with this one, people know that they have to test. They know the importance of testing. However, what we are seeing is that young people in particular, especially young males, are very scared of testing. And the reason why they are very scared of testing is the possibility of receiving AMA results that are positive. So with that also, we also said, then it means in terms of the awareness of the HIV and AIDS, then we are not doing justice if people are still scared to test. Because at this point, people should be testing, and if they are positive, they should be initiated on treatment. And then in terms of treatment, young people are aware of a treatment, and majority of them who test positive are actually taking treatment. And then viral suppression, this one is a bit of a challenge, because when in our public clinics, majority of the time when you go there to do your bloods, the clinicians don't exactly explain to you what it is that they were looking for, how are your results. They just take your file and then they say, okay, fine, we'll see you on this date. So this is a bit of a challenge. And then we also identify that the healthcare system, the public healthcare system is very strained. The resources are limited. So sometimes it could be the reason why they don't really have time to actually take you through your file and your blood works and everything. Thank you so much.
Thank you very much. Table 9. Is that the last table? I think others, okay.
Good
Functional.
afternoon, ladies and gentlemen. I'm Thandekile Msebi from Zululand District, Department of Health. A lot has been said by the colleagues on the questions that have been asked, but I'll just go straight to what maybe we need to strengthen in our communities. The presentations that were shared talk more of the men not accessing our services. And then the question was, where are these men? Why are we not accessing them? And the response was, most of the men are in the workplace. So have we done enough to access those men? As employers, are we having wellness activities that focus on men so that we can get them tested and then keep them on the program? And then another thing was looking at the children. We are really sharing information. We have said a lot that the information is available on different platforms, but is it enough to get them to understand what we need them to do, or what they need to do in order to plan their future? So in order for us to be able to reach this young generation, yes, there are modern ways of communicating, which is social media. And then also, the parents, what is the role of the parents? The parents are there, it looks like they have shifted their responsibilities. The teachers are going to cover, especially when it comes to sexual reproductive health. The teachers are going to cover, or they rely on somebody else to educate their children. That is where we are missing the boat. So we need more educative activities that will focus on the parents. To make an example, there is Umkhosi Wesivivane, which focuses mainly on women, how to, if you are a woman, how to become an effective mother so that you can raise your children. So if we can have more of those activities that focus on parents, so that parents can come back and own their children and take their responsibility, because education, the first education to a child begins at home. And then we are driving towards building resilient and self-reliant communities. One of the speakers, I can't remember whether it was the program director, touched on the integrated multi-stakeholder health promotion strategy. If we can all take the strategy and move with it, we believe it can yield positive results to all our communities, because it touches each and every one. If I were to be given an opportunity to project, there is one picture that is on the strategy that talks more, it just shows the communities or the people that we are living with, that if we can direct all our activities, our thinking and everything to these people, then we will be able to achieve what we want to do. And then with regards to the programs that are there to empower, especially our young women, we do have PEPFAR-funded programs like Good Dreams program, though it's there, but it's not enough for a person who is sitting in an area where this program is not there. It's difficult to see which there is something that is happening. So we need more of such activities that will capacitate our young girls to take ownership of, or to take charge of their lives, and then not rely on the men. Yeah. I don't want to say something negative, but we want our young girls to take charge of their lives. And then we have also noted on the presentation that the activities that we are doing, there is a different reception in different communities. We have noted that in rural areas, this is happening, and then in urban areas, yes, we have programs like You on You, or in Konje.
You is equal to you.
Equals you, and the other one, the Kosombala Machita, Nozikhala kanjani. Yeah, I wanted to uzikhala kanjani. That if you uzikhala kanjani, if you go to an urban area, the people there, the youth, they will understand better. But the reception will be different if you go to the rural areas. So that tells us which there is no one-size-fits-all program. So we need to look into that. And then there is one last thing, a program director, which is talking to stigma, not because people are being stigmatized, but there is a gap with regards to psychosocial support and mental health in all the services that we are doing. So right now, when you look at a person who say, I'm stigmatized, it's not because somebody is doing something to him or her, but it's the mentality within the person. So which then says, as much as we do have the professional mental, psychosocial support, our clinical psychologists and our social workers, but the reality is our communities, immediately if you touch, you say, go and see the clinical psychologist, you're going to get a different response. It's either the person who is just completely shut down, and they will never come back to use the service, because the person will perceive that you are telling them that they are mad. So there is a need for us to come down to the community, strengthen our community level support. There was a suggestion that what about capacitating the existing cadres, our community health workers, to have some sort of capacitation with regards to giving psychological support, because the people tend to bond more and open more to the people that they are living with, other than a professional person who would come maybe once in a week and then give you an appointment for another day. But if that service is readily available in the community, it would yield better results. Thank you.
Thank you very much. Table number 10. Do we have table number 10? Okay, we are done with the tables. Thank you very much, colleagues, for your contributions as well as your participation in this session. Now we'll move on straight to the reflection by different departments as they are listed here. So we can move because we are behind schedule in terms of time. Ntia, let me start with you on the civil society part. You have your 3 minutes. And some of the things are covered. So now we are just giving the civil society to express their views, although some of the views were already expressed in different groups that they are participating. Not that we are giving them less time, no.
Thank you very much, Chair. As you are alluded that most of the things has been said during this engagement from the tables. As it's written here from the program, my name is Richard Shandu from Civil Society. Morning, everyone. All protocol is observed. Oh, good afternoon. Yes, ladies and gentlemen, as we are here, for my short reflection on the research that has been done by our researchers. Thank you very much, SHRC. You have done very well the good work for us, and we have yet a lot of information, what we have done in the last few years. And we are really appreciate that what we are doing. However, as KZN, we are mentioned as the province that is doing very well in terms of 95, 95, 95. But second 95 and the third 95, we're still not doing very well. As even the report is saying, that means there are a lot need to be done by us, all of us, in order to reach this second 95 and the third 95. The challenge of retention to care is still a problem. The challenge of the viral load suppression is still a problem. STIs, early pregnancy, and also illegal abortion, still happening. So we need to find that what are the causative on these social ills. Under the prevention chairperson, on preventative tools, it raises a question to say, are the condoms still convenience? There's no high demand on condom in South Africa. People are still need schoon. They're enjoying schoon. Is the issue of the other question that I'd like to hear, of which we need to engage on in the future, is the issue of one size condom. It's fits all. Is it still relevant? Because I remember 2015, the Children's Sexual Act was gazetted and introduced, which is saying the child from 13 to 13, they can have sex, unless if there's no age gap, 14 to 14 or 13 to 14. However, that policy need to be challenged, because if the Children's Rights Act says the 0 to 18 years, it's a minor, she or he can't take the decision, him or herself. When they were introducing this act, they didn't review the preventative tools. So right now, why I'm saying that, the question will be, the 13 years, can the condom fit the 13 year? If we say one condom fits all, maybe we wish the researchers to assist us. We need to research on that. It's serious. Because even in adult, it might happen that there are some men having a problem, same problem, that their sizes are bigger than that condom, or their sizes are smaller than the condom. This is serious in terms of prevention. Because we might say the people, there's a
Colleagues, let's just have one meeting. Let's just allow Mr. Mtia to.
So we might say there is a bad attitude to men in using condoms. Amadoda ayasaba ukuphoxeka to say, hey Ness, this size is too small for me, or this size is too little for me, or too big for me. We must talk about all these things. We must talk about why I'm saying this, because Chairperson, when I was attending international conference at German, we visited one of the table in village. They were displaying different sizes of the condoms. Different sizes. That it came back to my mind that, is it happening? When I came back, I also did the engagement with some war rooms chairpersons. Some told me that some of the people come and say, hey, this condom is just, they said this condom is too big to me, or this condom is too little to me. So we also need to revisit this thing.
Yeah.
You see, this is a measurement of the sizes in other countries. When you collect your condom, you mentioned that maybe you have 57 millimeters, or 53, or 47. We can take it as a joke, but this is very important leadership that we need to look at. Because we might say people are not using condoms, but they are scared to come out and say, the size of the condom doesn't fit me. This is the message that we are giving to our researchers, and also us to listen to our community. In terms of PrEP, we know that there is a stock out on PrEP. We never know whether it's a manufacturer problem or we are not ordering enough from the manufacturers. Maybe because it's a problem from private and public. It's not only the problem from the department. So that's why we need to look at, to hear that where is the problem on this PrEP issue as we have a stock out.
As you sum up, Ndabezit.
As a sum up. However, we are really appreciate the work that has been done or doing by the researchers, research organization. Today we have Ulo Uyu is called to you, and we have TLD, and and better adherence, treatment optimization through our researchers. Thank you very much. Can we give them a round of applause?
Thank you. Yeah, no, thank you very much, Ndabezitha. Although it's difficult sometimes to tell your boss that you must sum up now, because civil society is our bosses. But I had to. All right. I hope Mr. Mdebele will also adhere to the call Ndabezitha of the sizes, because we are going to Mr. Ndebele is there. So, yeah, so we'll be getting a reflection from the Department of Health from Mr. Mdebele. I hope you will also address the issues of sizes. I'm not going to comment about issues of sizes, but yeah, I hear you.
All right. Thank you so much, Chairperson, and thank you to HSRC. The information is valuable. It actually assists in terms of planning.
If you can also introduce yourself, Babu Mdebele.
Oh, I'm Jabulani Mdebele. I work for Department of Health at a provincial level. So I was just thanking the SRC for the information that they presented to us. It's the information that is valuable, and it's more valuable nowadays because of the financial constraint. So if you want to do plan now, we have to do a targeted planning. So if we know where the problems are, it's easy to zoom into. So my request is just that if they can go a little bit down in terms of the findings at a ward level information, because most of the activities are happening at the households and community level. So it's becoming easier when people know in their own village they've got a problem of HIV. So if you put it upwards, people tend to associate that information to say, it's their problem. They don't see it closer. It's just a request that as they develop, because now we have got a district information, so now let's go closer to the ward level so that we can do targeted planning. Thank you so much.
No, thank you very much, Baba Mdewe. Let's give Baba Mdewe a round of applause. Okay, our next victim is Dr. Kambush. Your reflection, Dr. Kambush from Education.
Hey, my leader, you're calling me today a victim. Okay. Okay, thank you very much, colleagues. Much has been said, really. If I were to give details on how we're looking at it as education, I would end up repeating what it has been said. However, I would like to say thank you very much to HSRC in terms of the results. They are very important. To echo what also Mr. Mdebele has said, it's going to assist us. It came at a right time where we are going to planning for the next financial year. Our plans are done now. Until December, we'll be doing our plans, operational plans, business plans, putting more resources in this area and in that area. It is very clear in terms of where the gaps are. I was more interested in the 15 to 24-year-old because that is where the bulk of my clients come from. I'm Spongsen Tongo. I'm from the Department of Education at a provincial level. Perhaps I needed to start there. So I'm from the Department of Education. So what I want also to emphasize is to say, those 15 to 24-year-olds, I did have a talk with Prof. Zuma to say I was very much interested in knowing of those 15 to 24-year-olds, how many are actually at school and how many are not, how many are at universities and how many are. It will even give us a clearer picture, but he did also promise me to say that information is available. We want to say thank you very much, Mr. Lewis, because you're saying you are open to us. We can get whatever information that we need further to what you presented. Why I'm saying this is because we still have a lot of them dropping out of school. And those that drop out, and we do know that the school itself, it is a protective factor. Research has told us that if we keep them at school, we are, to a certain extent, protecting them. But one thing that is a little bit depressing is that some of the things that you are hearing here, your multiple sexual partnership, early sexual debut, and so on, we have had this thing long time ago. Perhaps the question that we need to ask ourselves as we're going for planning is, why are we not defeating this thing? Are we backing the wrong tree? What is happening? Are we throwing the stone into the bush, hoping that the lion will jump out? What is it that we are actually doing? So as we are going for planning, maybe we are not doing the right things, or maybe we're doing the right things but not in the right way, or maybe we're doing the right things in the right way but not enough of them. But maybe we need, those are the questions. This research has given us a lot to think about as with Department of Education. But lastly, what also we are seeing is that these things emanate mostly in communities, as the school is a microcosm of the community. I think we need to be more in touch with the communities as well, and so that we know exactly what's happening. And recently, we have as the Department of Education and Innovation, which is called Parent-Child Communication Program, where now, because most of these people, it came out, when you look at it, it's the parental guidance. I think it was mentioned by the reporter, even from our team. Now, the parent-child communication, where we are encouraging parents now to have an honest discussion with their children. Not to ask them, go to the school, the teachers will tell you this, and everything to the teachers. Having said all of that, I think a lot of introspection from our side. Thank you, Mpepet.
No, thank you very much, Kambushe. Kutoka education, it's only the environment where the service provider beats its client. It's not me, but they are saying that. I'm a client and shy. Thank you very much. I won't comment on that. Okay, TST. I'm Zizi.
Thank you so much, Chairperson and colleagues. As DSD was so much interested and very happy about, okay. I'm saying as Department of Social Development, we are so much excited about the key findings today. If you could remember, Chairperson, whereby I think it's some 4 weeks ago, where we needed to consolidate as government departments the statistical data and the findings on HIV and AIDS at KZN to go and present to our new GNU political leaders. We struggled till 1:45 in the morning, where we were contacting one another, Department of Health, can you have this current statistical data on HIV and AIDS prevention, until we went into the Google account. We'd like to appreciate very much SRC for what you have done to us. I'm just sitting here and telling my other colleague through WhatsApp, don't stress when we have to go and brief our honorable MC on HIV and AIDS. I do have the data now of what is happening across the district, because we were looking geographically, globally, hence per district. I remember Dr. Jamin is here. I had to WhatsApp her at 12:30. Dr. Jamin, kindly assist me. I'm a program implementer, but I'm not a researcher. I just need this information, but thank you so much. I would like also to thank HRC for the identification of the hotspot areas in terms of the demographics. However, into the findings, I haven't heard the causal root of the high incidence in terms of prevalence in the Kungundlovu, King Cetshwayo, and the Tegwini. Reason being, there's an oversaturation of program funding from the government, from the social partners. Hence, there is still a high rate of HIV prevalence, and especially among the 15 to 20 year, and especially among the 50 to 59. If they could look at the social impact of it, I think we could have seen of how best can we improve on program implementation. And the other one, it's on the monitoring and evaluation in terms of the performance management of the projects, meaning the commemoration of the calendar of events day by government department and social partners, including the program implementation across government sectors and the social partners. Reason being, if we may take the statistics of King Cetshwayo, we've got so much officials at King Cetshwayo implementing HIV and AIDS program. And again, we've got so much social partners, NGOs, FBOs, CPOs funded implementing HIV and AIDS program in Gungundlovu and King Cetshwayo. Hence the outcome when we look at the HIV AIDS incidence and prevalence, we seem not to have achieved. And also we'll also need to look at the impact of the socio-economic conditions as a result of the key drivers that we have highlighted, which then it's calling for the research to be done, as we're mentioning, on the household and individuals. Would have loved to see what is the nature of the family structure that we have met when we were interviewing the household and the individuals. In comparison among the rural as well as urban. Because when you go to here, just we take here at the next around Durban.
Yeah, as you sum up.
I'm just summing up, we need to, if you go to Umlazi, Angiti, we see there's quarter camps, and the family structure there, it's fat and set. Ne? And then when you go to Mkomazi, or let's say you go to Mkanyagude, it's the granny, grandchildren, family structure, which is the primary caregiver, it's the granny, and the child, there's an age gap. In summary, in your research, yes, we see it's biomedical, but can we look at the social impact, which then, looking forward after 10 years or 5 years to come, it will give us an idea of the real program implementation. Thank you.
Thank you. Let's give Mamziz a round of applause. Okay, let's come here now. It's a reflection from the Office of the Premier. I'm sure you will be very brief now because I've already made my reflection when we are starting this session and my reflection. Yes.
Okay, thank you, Chair. Thank you, SSRC, for this workshop or meeting. My name is Tembile Dlamini. I'm the technical lead for community and stakeholder coordination, seconded by Match at the Office of the Premier. We have noted that the PIP 2017 to 2022 for HIV, TB, and STIs has made great strides despite the challenges that were brought by COVID-19 pandemic, the flooding, and the civil unrest in KZN. I think we should give ourselves a round of applause for that. So, with the PIP and term review that we did for the province, we also noted the reduction of new HIV infection by 40%. The key challenge then remained with the second 90, which we were sitting at 79%, but today it was reported we are at 93. So there is some disparities there. And then the sexual assault remained high also. We were reporting about 1,000 offenses per month, with the below 12 at 300 per month. That was reported then. This current PIP now, the 2023-2028 is the last document that will usher the province towards the 2030 vision, which aims at achieving HIV-free generation. So I'm not sure whether it goes or So we are saying this PIP, the current one, is community-led, youth-focused PIP with the inclusion of mental health, viral hepatitis, and also cervical cancer. What are the strategies that we are having? The focus, I think, should be on the ages 15 to 24 and also 25 to 49. Also, we need to focus on urban and informal settlements. The recommendations, therefore, will say we need to strengthen coordination using Operation Sukumasake, the TTM model, and also the AIDS Council. We do have those, but we need to strengthen. We need to ensure mainstreaming, collaboration, and integration of services between stakeholders and within the organizations, including the information system. If we can have a client unique identifier, then it will be easy for us to sort of like follow that client in whatever department that they can be. We also need to ensure integration of campaigns. For example, men's campaigns. We are saying from DSD, we have campaigns that are focusing on men, boys, men championing change. We've got MENA campaigns from DOH, we've got men's forum, we've got men's sectors. So we need to ensure, as the Office of the Premier now, Mr. Chair, that we coordinate all those campaigns. We have meetings where they report in the work that they are doing. Secondly, using health promotion strategy as a wheel towards achieving health for all. And then we need to disseminate this information now, these results. We need to go back to our communities. And where we will be using the language that is simple, the language that is specific to those areas, using absolute numbers so that we ensure that the people at local level understand the information that was discussed here. So we've got district AIDS coordinators here. We also have district directors. So we need to ensure that we go back, call stakeholder meetings so that we can then disseminate this information. The importance of the role of civil society that has strengthened our advocacy for the people of KZN. And then we also need to review the policies. Well, we need to come up with innovative ideas maybe, especially when it comes to access to learners for Department of Education. What innovative ways we can come up with so that we can access those children. And then we need also to look at the issue of vetting for people working with children. How do we vet those people? Because some of the challenges are coming from those. And then let us strengthen the social behavior change campaigns, awareness campaigns, the use of media platforms, as it was mentioned, especially for prevention strategies, condoms, PrEP, SRH, U equals U, and so on. And then let us bring back the focus for impact. In the focus for impact, we're looking at where are the challenges? Why are we having those challenges in those areas? Who is at risk? And what interventions do we bring? So if we can focus on that, I think we can then succeed as KZN. Thank you very much.
Thank you very much. Let's give them a round of applause. All right, colleagues, thank you very much for your contribution as well as your reflection on this program today, and I hope that some of the input that you have made, Dr. Makulu can come closer now as we are closing, so I can hand over to you. But I just want to appreciate the colleagues and thank my colleagues in terms of their participation as well as their contribution, and I'm hoping that we will get the reports on this session as based on our contributions from different sectors that are here or from different stakeholders that are here, and I'm sure some of those reflections will also be part of the engagement with the cohort. The cohort is a committee of HODs because we were supposed to start with that engagement first, but due to a number of activities and other competing activities, we ended up starting with this session where we are just engaging stakeholders. But on the 10th, colleagues are still coming back to present the same report to the cohort, to that committee of the HODs, so they can also understand this report when we go back to them in terms of the interventions as well as the responses that we're expected to do in relation to this report. And thank you very much, HSRC, for this session, even to give us a clear understanding of this report, as we are maybe some of the people were celebrating on media, saying, yeah, no, we're making any paper. But when you get to understand the interpretation of the report, you realize there's a lot of work that still needs to be done in relation to the to HIV and AIDS responses in the province. Thank you very much, Doc. Over to you.
No, thank you so much, Mr. Mzimande, for really leading the session. It has gone well, and I'm happy that you were really noting the time. So, colleagues, we are almost at the end. I'm just going to ask Dr. Sean Jooste to just close for us while we load the evaluation, the link to the evaluation form. So, as he speaks, the colleagues can just help you to also just connect and ensure that you evaluate this session for us.
Thank you, colleagues. So my task is just to thank you. We really appreciate each one that attended in person and also those attending online. We were very worried because tomorrow is a holiday. And we were so scared you'll come here today and we find empty tables. It was a very robust discussion. I think it was well led by our leaders here, our co-chairs. They kept you on time. They kept you, to this. We started a bit late, but we have finished on time. We also like to thank the organizations that you're coming from for allowing you to be here to spend the time with us. Just to assure you, we are going to share the presentation with each and every one that registered, that you can share this presentation to your networks. We're also working on a provincial report. It was mentioned. That adds a bit more detail because we couldn't present everything. You will also get that provincial report. There'll also be a report just summarizing today's event. We will share that with the province. And I think, as was mentioned, we want to be a resource. It's the first time that we are coming to provinces. Normally, as an invite, we will present at a meeting. But this is the first time that we are actually going to all provinces to do a dialogue, to share the results and get people that's involved in HIV to talk about it. We are so happy that it's come at the right time, that you're busy with your planning. So we are there as a resource. So anything that you require that we can provide you that's not in the presentation or in the report, we have the data. We can then see what else we can give to the province. So we're hoping that we can become that partner. We do lots of research in the area, in the provinces. This is our biggest province. The HIV, this is the burden where HIV is. Most of our teams for the survey was in this province. This province has the largest sample. So lots of resources is actually spent from our survey onto this province. We would also like to thank the Office of the Premier and the Provincial AIDS Council for behind the scenes, arranging, sending out invites, coordinating. We had lots of meetings with the office and with our team just to make sure that we get a diverse group of people. And I think you could see it at the tables. You got people speaking from different perspectives. You got government, you got civil society, you have social partners working in the area. So we're very appreciative of that. Just to be here, we are just so grateful that you're able to, open up your province to us, and we really appreciate it. Thank you, colleagues.
Okay. No, thank you. Okay. The most important
one. Look, as I mentioned, it's the first time we ever do this, right? And you can imagine the costs associated with this activity. This is now the 6th province that we visited. We only have 2 left. No, sorry, 7th. We only have we're doing the Western Cape on Thursday, and the final province is Northern Cape. Without the support of PEPFAR, because they felt that dissemination is so important. We sometimes only have a report, and we share the report. But actually to go back to each province and have provincial reports is so important. So we'd like to thank PEPFAR for providing that funds, and also CDC facilitating the whole process. Thank you.
No, thank you so much for that, Dr. Jooste, who's the co-PI for the SABSSM project. Colleagues, just 5 minutes to allow you to go through the evaluation, please. We would really appreciate to get feedback from you. And then just to note that the restaurant is downstairs. So as you make your way for lunch, it's on the ground floor. And please ensure that you have registered. We have circulated attendance registers in each table. It should have your email address as well, so that we're able to send all the necessary information as stated. Once again, thank you. Travel safe, and we should meet sooner than later.